เคก็วันในวันนี้นะlet me speak in Thai first and then after that I will in English โอเคก็เดี๋ยววันนี้นะครับก็จะเป็นเซสชั่นเช้า9โมงถึงเที่ยงที่ทุกคนจะมาได้เรียนรู้ร่วมกันในเรื่องของa whole person approach in stroke rehabilitation นะครับซึ่งเราก็จะมีทั้ง on-site แล้วก็ออนไลน์ให้กับstaff rehab staff ทั้งเครือ BDMS นะครับก็ในขั้นต้นนะครับผมก็จะขออนุญาตเรียนเชิญผู้อำนวยการนะครับ Let me speak in English okay we would like to invite Dr. Metini Maipeng the hospital director and CEO Group 1 to give a welcome speech please give a big applause to our director please
สวัสดีทุกท่านค่ะสวัสดีตอนเช้านะคะยินดีที่ได้เห็นหน้า Good morning to our friends from Oregon Hillside University and our energetic BDMS staff. Firstly, I would like to welcome the group of our friends. Let me read your name. Andrea Angelina Jolie. And Catherine from OHSU. Well, I would like to welcome you all to, and then our energetic BDMS staff, physician, nurses, and rehabilitation people. Firstly, I would like to welcome the guests, OHSU staff, and the staff from BDMS all over the country to Bangkok Hospital headquarters. I know that you are today so excited to learn something from our friends from OHSU. But let me, going back to like 10 years ago, that we start our relationship with OHSU. And during these 10 years, the rehabilitation are always the main focus of the relationship. And right now, to this period of time, I think this 3-year period, 2024 to 2026, we are focusing on the rehabilitation of the our 4 excellence center, namely the cancer, which is not that much, with another 3 excellence center of the rehabilitation services, the orthopedic and trauma, and neurology, and what else? Cardiology. So this is our main focus. During these past 3 years, we are doing the train of the trainer. But at the moment, during these 3-year periods, we are focusing on another aspect, meaning that we try to develop our guideline of the stroke and maybe another 2 or 3 aspects of services in our BDMS. If we can develop the guideline together, even in our BDMS, we have like 58 and more to come hospital during the another coming period. And in our 58 or 59 hospital at the moment, we have several tiers of hospital, and taking care of the number of patients is different. But anyhow, if we can develop the guideline and then make it match with the level of the hospital, that would be our objective of during this 3-year periods. And the first one would be the stroke rehabilitation stroke of the whole BDMS. That our objective of the today and during this coming 3 years. So right here they put me to read the so many things in rehabilitation, but I think everyone knows, so I don't read it over. And lastly, I would like to thank you to come very long way, like half of the group, to helping us today. So please accept my true appreciation with your team. Thank you so much.
Okay, yep. Thank you very much for our director. Let me briefly outline today's session with include 5 key parts เราจะเรียนกัน 5 ส่วนนะครับ First, cognition and communication presented by Catherine. Interdisciplinary team care presented by Catherine, Angelina, and Andrea. Physical therapy assessment and intervention presented by Angelina and Andrea. Fourth, question and answer session. This is more important for you. If you have any question, you can ask all of them. And the last one is brief review of research. Okay, before we dive into today's content, please join me in giving a warm round of applause to all of our instructors for their work hard and commitment to our professional development. And thank you, and let's get started with today's exciting session. Okay, please give a big applause again.
Good morning, everybody. So my name is Catherine. For those of you who are not familiar with the role of a speech-language pathologist in the United States, it's a little bit different. So my domain is actually quite large. So of course we see speech for dysarthria and apraxia. I work primarily in cognition, so changes in your thinking, which we're going to be addressing today, communication due to aphasia. That can also include social pragmatic changes, swallowing, of course, and voice. My background is I've been at OHSU for the last 2.5 years, and I work in a clinic that specializes in cognition and communication. So it's a little bit different because I'm not seeing patients anymore with swallowing and voice. We have other speech therapists who work in that population. I only work with adults and some teenagers, 16 and up, but my previous experience has been primarily in adults with neurological impairments and changes, as well as geriatric care. So previous to OHSU outpatient, I worked in home health, nursing facilities, and acute care. So I've kind of seen the whole span of care over the years that I've been working. For those who were with me for stroke rehab, this might look a little bit familiar to you, but some of the things I wanted to talk about today were strategies for cognition and communication that you can all use, even if you are not a speech therapist. These are going to be ways to help you working with patients who have had a stroke, a brain injury, any other kind of neurological change that are experiencing changes in their thinking or their expression or understanding of language. So boot camp, we're going to be fast. I'm going to be asking you lots of questions, so I hope everybody is well caffeinated because your brains are going to be working in a second here. I had a much more exciting version, so here we go. All right, I told you I was going to be quizzing you. So everybody, back to school. Anatomy and physiology. We're going to keep this really simple. I want you to think about what changes can happen cognitively and as far as communication goes when a person has a stroke on their dominant side with left hemisphere injury versus right hemisphere, which is going to be non-dominant. So I'm going to give you guys a moment to think about it. And again, thinking about cognition, so things like attention, memory, problem solving and planning, and language, right? So that could be writing, speaking, understanding. Give you guys a couple seconds to think about it. And then I'm going to be calling on somebody. We can have a volunteer, or I'm going to choose. Anybody willing to volunteer a try for either? Yeah, I had a feeling you were going to volunteer. All right. For which one? Left-sided? Left hemisphere stroke? Okay, yes, definitely. Yes, there could be language changes, aphasia, whether that is expressive or receptive. Does anybody have any ideas for the right hemisphere stroke? Right, the thought organization isn't necessarily there, absolutely. Right, they may be able to communicate, but it's not going to be as well organized as we would expect. There might also be speech changes. It really depends. So good, nice job. And you guys got some delicious American candy all the way from Portland. Yes, so this is going to depend, right, where the injury is in the brain, but as an overall guide, left-sided, language changes. So like we said, that's communicating receptively, taking in information, and expressing what you want to say. Things like trouble thinking of the word. I think that's what we think of with the classic aphasia patient, right? Speech changes, motor planning issues, trouble with rational and logical thinking, verbal processing, so difficulty taking in information quickly, and then poor verbal memory, whether that's short-term or long-term. You speaking to your patient and giving them verbal directions might not be the best strategy for this kind of patient, and we're going to talk about this more. And then what about right hemisphere stroke if it's their non-dominant side? Language changes again, but this is the social changes. They might not be totally appropriate. They say things that don't fit into that situation correctly. They're not behaving as we would expect them to. Speech changes, prosody. So if you're not familiar with that term, that is almost like your pitch and intonation. So if I spoke like this the entire presentation in one pitch, that is a prosody. I'm not talking like that, right? Trouble with creative thinking and problem solving. Hyperfocus, getting stuck on one information, one action. Changed emotional responses, visual neglect, and visual processing and memory. Some of these things, as a speech therapist, I focus on more. A lot of times the visual will go more to occupational therapy, but there are strategies that we can use as speech therapists as part of our treatment. The interesting part, right hemisphere disorder, right? So it looks a little different because we might come to this patient and think, they're doing okay. They're covering up. That's what's happening. Because they can talk their way around what's difficult. But they're usually pretty talkative, so they'll be using a lot of words to cover up the fact that they don't actually have an answer to your question or a good way to solve that problem. Again, those emotional or social changes and speech changes. This is something that you might not notice immediately when you first come across your patient, but as you start to poke a little bit more and more and asking them some harder questions, all of a sudden it's going to become apparent that their reasonable thinking, their logic is not quite what we would expect them to be, especially if it's somebody who was independent in the community beforehand, and now they're not able to tell you how they would get from the hospital to their house. So, as a speech therapist, this is what I'm talking about when I say cognition, and you are all more than welcome to use this image if you like it. I'm addressing all of these things with my patients. Energy, look what's at the bottom. So as a speech therapist, there are some pieces here that I can address, right? Sleep hygiene, I can talk about good sleep strategies, but if somebody has sleep apnea, then I need to refer them out. Pain is not in the domain of a speech therapist. Again, that might be physical therapy, doctor, balance and vision, OT, PT, that's you. Stress, mood, activity, medication, right? All of these parts are people who are on your team, and they're going to affect somebody's thinking process. So this is where I like to start, right? What's somebody's energy, and what would be potentially affecting that, and that's going to affect your outcomes in your treatments. Everything builds on top of each other. So if I'm here on 2 hours of sleep, if I had just come in from Portland, my attention would be bad. I'd probably be losing my train of thought. I'd have trouble thinking of words, right? I'd be forgetful. I probably would have forgotten 10 things that I needed for today, right? So it's not that my energy is low and I can't do these things. They just become much more difficult, right? With a stroke, we know that these skills are still there, but the access point is not, right? So we're trying to rebuild that access through therapeutic approaches. Just because you're having trouble paying attention doesn't mean that your memory is gone. It's just going to become much more difficult to actually hold on to that information. And then on the other side, right, cognition, now communication. Most frequently in stroke, we're talking about aphasia, right? This is very simplified. It's not only in stroke, right? We know it happens in brain injury as well. Certain dementias, we have aphasia. But we're thinking about all the aspects of what we need to communicate. So speaking, thinking of the words, organizing your thoughts. Writing, same thing. Reading, taking in information, right? What's that going to do to you if you are not able to access the written information around you? And then difficulty understanding, whether that's understanding what people are saying to you, or again, what's written. It can also include, again, social gestures. That can be a part of aphasia. All right, so you're meeting a patient for the first time, right? You're going into their room. Things you want to immediately consider. Are they responding to you, right? Are they oriented? Do they know where they are, why they're there, what day and month it is? You don't have to go in and quiz the person and say, what's the date today? Why are you here, right? You can make it conversational and really starting to build that rapport, because I know I come in, oh, hi, I'm a speech therapist. It's so nice to meet you. My speech is fine. You can go, right? Well, I'm here to, right? I have to explain to them why I'm there. And that's going to start building that relationship with your patient, because most likely you're going to be seeing them for quite a while. So you're trying to get that buy-in pretty quickly. So you can get a lot of information on somebody's cognition and their communication just in those basic, hello, how are you? It's nice to meet you. And if you're going to start therapy with them, right, are we helping them succeed? Do they have their glasses so they can see? Do they have hearing aids? If they have trouble hearing, maybe if I think a couple of actually I think everybody in our stroke group got those over the head earphones, yeah, where you can amplify your voice. Something like that is an easy go around. Do they have water, right? Are they hungry? Do they need to go to the restroom? And then the environmental piece, right? Especially from cognition. For cognition, if you're going in and the nurses are coming in and out all the time, it's really noisy in the hallway, right? They can hear all the machines from the other rooms going, or the nurses chatting. That's going to be really distracting for somebody who's having cognitive changes. And basic things, right? Is the light on? Is it too bright? Is there too many things on their table that you need to clear off before you get them to focus? This is all pretty simple, but it makes a big difference for somebody, especially in their beginning phases of stroke recovery, because we really want them to be in a place where they are ready to learn. That's what we're going for, right? They're learning. All right, so moving on to communication. This is called triangulation, this first piece, right? So especially with somebody with aphasia or some more mild communication deficits, right? Sometimes the message isn't always clear. And if we're asking a question, they might actually say two opposite things, right? Oh, you want chicken for dinner? No. Okay, so what do you want? Chicken, right? So this is the idea of triangulation. Are you hungry? And they say yes. Okay, you're hungry. Let's get you something to eat. It's very simple, right? But that way you make sure you're on the same page all the time. Are you ready to stand up? We're going to stand up now for physical therapy, okay? No. I'm sitting. Okay, you want to sit down for another minute? Yes, right? Simple. It doesn't have to be very complex, but you're just reciprocating what they are communicating to you. All right, so let's do some practice of communication strategies. But I'm going to open with a question first. If you have somebody with aphasia, well, how are you communicating with them as a therapist? Anybody have any go-tos if you have to give somebody a direction and they don't understand or they don't know how to share what they want to communicate? Any strategies that you like to use? I'll give you guys another, yeah? Go for it. Yes, body language, absolutely. Gestures, absolutely. There you go. Piece of candy for you. See, you guys get sugar if you answer. Yes, yes. Body language, definitely. Pointing, right? As a physical therapist and occupational therapist, you can just give tactile cues, right? If you need them to straighten their leg, you can just tap on their leg, right? Whatever it is, that's simple. But we can also use pictures, writing, our phones, right? Those are a huge tool that we're able to use these days, especially with patients who are already using their cell phones day in and day out. They usually have pictures of things that they like, maps. We're going to use some of this. Angelina or Andy, can I use you as an example? Yeah. Markers. Okay, I'm going to move over here. So, co-constructed communication is the idea that we're having a discussion around a topic with multiple pieces of input from both the speaker and the listener. Supported communication, we're going to talk about in a second, is how we can make sure that we're getting the correct message across. And then multimodal communication is allowing for things like using your cell phone, using pictures, gestures. You can use all of these in one. So, I'm going to have you be the therapist.
Hello, Catherine. Where are you from?
Okay, so you asked me where I'm from. Very far away. It's got these big buildings. Busy, so busy. Yeah, you know what I'm talking about? Yeah.
Could you mean from a city?
Yeah, a city, right? So, as a speech therapist, I could write city. That's it. We're starting, right? We're breaking it down. All right, I'm going to switch roles because I think this might be a little bit easier, yeah? Okay, so you're from a city. Is it on the West Coast or the East Coast?
Well, the water is on the left side, and yeah, we drive to the left side when we go to the beach.
Oh, yeah. Okay, so that sounds like the West Coast, yeah?
Yep, that's right.
West Coast. Oh, yeah, so it's easier to see. Thank you. Yeah. So you're on the West Coast. Cool. All right. Well, there are 3 states on the West Coast, so I'm just going to go through them. Is it California? Do you live in California?
I don't think so, no.
Okay, not California. Next one. Do you live in Oregon?
Yes, Oregon. Yes, that's where I live.
Oh, okay. So you live in Oregon, yeah? And it sounds like you live in a city. The city I know in Oregon is Portland. Is that where you live?
It's like you know, yes, I live in Portland.
That's key wording, right? I was just writing down the key terms of our conversation. You can almost think about it like closed captions. but it's just the basic one word. You can use this to get answers out of patients. What do you want for dinner? Ooh. Angelina, what do you want for dinner? Do you want chicken soup? Or would you like tomato soup? Do you like chicken soup?
I don't know. I don't know if I like chicken soup.
What about tomato soup?
I love tomato soup.
Okay, so maybe tomato soup's a better option for today. And you're crossing off. You're using symbols. That's it. It's very simple. I'm not putting a lot of information on here, right? It's so the patient can follow along, and it's great if they can see this, because a lot of people with aphasia actually do better when you can see the writing along with it. So that way they get the visual and the verbal information, and it's reinforcing that message. So now if we were going to, I don't know that I necessarily need your hard work, Angelina. Thank you. So now if we were going to use multimodal communication, I might pull out my phone, or if you have an iPad, tablet, and I might pull up a map. Oh, you live on the West Coast? Running out of hands. I'm going to pull up Google Maps and have them show me. Oh, let's zoom in. You're on the West Coast. They might be able to point and show me where they live, right? Oh, I'm over here somewhere. Oh, it looks like you live in Oregon, yeah? That's multimodal communication. You're just giving them access to other tools to communicate. It's very simple, and I think a lot of this is naturally done in our day-to-day, even with our friends. I'm trying to remember the name of a restaurant. I can't find it. I look it up, right? You can use the same exact strategies with your patients. They are used to these kinds of situations too, so it's very easy to naturally build in. I think you guys will have access to this PowerPoint at the end, so you can check out some video examples of communicating with somebody with expressive versus receptive aphasia. All right. So, do you guys have a piece of paper or tablets? Everybody has something? Yeah? To write on? We're going to do a practice keywording like we did on the board. Can I use you again, Angelina? Sorry. So, what we're going to do is, again, mock. What I want you guys to try is I'm going to ask Angelina some questions. I want you to try keywording what we're saying. Okay?
Do you want me to give indefinitive answers? Description?
Sure. Okay. I'll try to narrow it down as we go.
Okay.
Yeah. Okay, Angelina. So today, I thought for therapy, we can do two things. We can go for a walk in the garden, or do you want to go down to the cafeteria?
I really like the garden, so I think walk in the garden.
Okay. I think the garden sounds really nice. It's a nice day outside. It's sunny. When we go to the garden, we can do two things. We can go look at the flowers, or we can go walk around the lake.
I think I'd like to see the flowers.
The flowers, yeah, there are a lot of nice flowers right now. All right, what are some words you wrote down? What were your key words? Flowers. And what was the second one? Lake, yeah. What was the very first thing that you wrote? Because I said, for therapy today, we can do two things. Did anybody write anything at the top as their topic? I'm going to come peek. Don't hide it. Yeah. Walk in the garden, yeah. What do you have, walk in the garden? Oh, yours looks good. Yeah, activity. Yeah, right? Yep, that looks good. So go garden, flowers, walk. And I like how you bubbled it. That looks good. You can cross off the things that they say no to. That way we know it's not on the table anymore. Yeah. You wrote down a lot. Let's see. Yeah. Walk garden. Yeah, exactly. I see a lot of garden walks. Anybody write anything different? Yeah, good. Garden, cafe. So the only thing, I see a lot of the second piece. I would just write choose or activity at the top, right? So that way they know what they're supposed to do. So they know that they need to pick between two options. But other than that, yeah, flower, cafe, walk. I see a lot of, yep, flower, good. All right, I've got a couple more tables to go through. Activity, yeah, right? Exactly, right? You're keeping it super simple. It doesn't need a lot of words. My recommendation would be if you are going to do this on paper or on a tablet, you're writing in large text in black ink. If you can get a black marker or a Sharpie, that's the best. There's actually a little bit of research behind that people do best with intaking information on a white background with black text. So make it big, make it simple, and when your page starts getting filled up, flip it over so visually it's easy for the person to track that information. Yeah, nature. That's beautiful. You all have such nice handwriting. I'm impressed just by the handwriting. If it were my notes, nobody would be able to read it. So, beautiful. Yeah, that looks good, everyone. Nice job. Simple. So, now when you go into your therapy sessions, you can make sure you have a piece of paper and a black marker. Easy, but add that to your go-to tools. You'll also see that some patients might actually try to write. That's going to give you some information. If you're an occupational therapist, there you go. You can see some fine motor skills, right? You can also start to see, is there any kind of language impairment when they're writing? Because maybe they can't speak very well, but maybe they can write. So it's an easy way to start seeing what their strengths and their difficulties are as far as communication. All right. So receptive versus expressive, it might be a blend. It might come across in different ways, like we said. It might be with the verbalization of information. It might be with writing. It could be a blend. So there's not one black and white box for people to fall in, especially if they've had multiple strokes. It's going to get much more complex. So if you're not super familiar with aphasia, just know it might be a mix, and that's okay. The way I was trained was you don't have to worry too much about saying, is it Wernicke's aphasia? Is it Broca's aphasia? I need to know, can they think of a word in conversation? If I show them a picture, can they name it or not? Do they understand what I'm saying? Can they follow a one-step command? Can they follow 2 steps, 3, right? So thinking about strengths and weaknesses, what can you capitalize on? What are they already good at that you can use to help use your therapy, to help your therapy? If they're really good at reading, as a physical therapist, you know, oh, I can actually maybe write down the directions for them, or again, use 1 or 2 words so they can read along and follow it if they don't auditorily understand. So just because you're not treating the aphasia, you still need to know how to communicate with them. Like I mentioned, the communication goes across different domains. So they might have trouble with math. This is difficult because sometimes there's also a cognitive piece to this, that working memory. So that can be kind of hard to parse out. Impaired writing, not because of a motor change. It's because of that language representation of the words. Impaired reading, impaired communication, and then we have that apraxia, right? Difficulty with speech. And again, it can be a blend. Somebody can have apraxia and aphasia, and that's going to make things really complicated. If you're a physical therapist, you might not be worried about all of this, right? But it's going to help guide how you are approaching these patients when you're treating them. So for my stroke group from Portland, this looks familiar probably. There are different errors that people with aphasia can make. They can repeat the same thing over and over again, perseverations, right? I'll show them what is this? And they'll say phone. Great, yes, it's a phone. What's this? Phone, right? No, this isn't a phone, this is a water bottle. Okay, phone, right? And they'll just keep getting stuck on the same word. Paraphasias, these are similar words, whether by meaning or by sound. So instead of saying a dolphin, they said a fish. Or instead of saying fish, they said fit. So they changed the sound. You can make up a word. They said schism for fish. They avoided it. What is this? Oh, you drink out of it. Yeah, but what's in it? A liquid. What's the liquid, right? They're going around it because they can't think of the word water. That's where people tend to cover up, right? They can't think of the word and they'll just go around. And that's okay. That's a really good strategy for people to use, but it's something to pick up on, that if they're not able to hit that one word, there's probably some language changes. Grammatical errors, and then just communication breakdowns. This is quite frequent when people have more of that anomia. They can't think of the word, and will get frustrated, right? Oh, it's a fish. I saw it in Hawaii on vacation. Never mind, right? And they give up. That's where you'll see people start getting pretty frustrated because they're aware of their errors. This is when those keywording strategies, multimodal communication, can really come into play, because you're going to help them communicate it, right? Instead of saying, don't give up. I want to hear what you have to say. It's okay that it takes time. I want to hear what you have to say, instead of saying, okay, yeah, never mind, let's move on, right? We're trying to make our patients feel like they can be successful with their communication, even if it's not the way they were communicating beforehand. All right, so if I show them this picture and I say, what is it? And they say, it's a cat. What kind of error is that? So it was a dog, and I said, it's a cat. Any ideas? Even if it's the wrong guess, go for it. Semantic, I heard it over there. Semantic paraphasia, right? They're related in meaning. They're both animals. They're both pets. Good, nice job. All right, what if I said it's a doctor? Phonemic, yes. They had the first sound, right? Da, but then they said doctor. What if I said log? Still phonemic, yeah. Good. Hooland. Neologism, right? It's a made-up word at that point. Yeah. Man's best friend. Circumlocution, right? So if somebody said that as in an assessment, I'd say, okay, but what's the name of this animal, right? And see if they can actually name it. Good, circumlocution. They're not wrong, but it's not the word we're looking for. All right, last one. This is a little bit of a trick one. Biscuit. So I'll tell you guys some background. My family's dog is named Biscuit. So what kind of error would that be? So in this case, it could actually be a semantic paraphasia, because for me, Biscuit is my family's dog. So now this is where paraphasias get tricky, because it's contextual to the person. Because if I showed you a cup of coffee, maybe you think sugar and I think milk. Neither of us is wrong, right? It's whatever your frame of reference is. Again, if you're not treating the aphasia, you don't necessarily need to write in your notes. Patient speaking with multiple semantic paraphasias was able to navigate through circumlocution. That's not what I'm expecting, right? If you see patients with aphasia, what I want you to take away from this is starting to notice patterns in your patients that you're communicating with. Because even if you're not treating the aphasia as a physical therapist, you need to be able to communicate with your patient. And if you start recognizing, oh, they always have a phonemic paraphasia, the first part of the word is always correct, and the second part is an error, you're going to start being able to communicate with them a little bit better, because you can say, oh, they meant dog, not doctor, right? When they said, I want to go for a walk with my doctor, I don't think most people would say that, right? But if you know they have a dog, right? Oh, you mean your dog? You want to go out with Biscuit for a walk? Yeah, I miss my doctor. You know, right? So even if you're not treating it, it's still really helpful to know what's going on to make you a better communicator with your patient. Right? So why does it matter? We want you to be a better communication partner with your patients. This is also going to help with family members, right? When they can see, oh, look, there are actually strategies that we can use to communicate, even if you're not a speech therapist, right? There are ways to navigate around this. If you are treating aphasia, it's going to tell you what you need to start working on. And it makes you the better communicator, right? It takes two to communicate. I have to be able to receive the message from my patient, and I also have to be able to communicate with them, right? So it's a two-way street, and I think it's pretty easy to think, well, they have the language deficit, right? Well, we're there to help bridge that gap and make them feel successful. You can cue your patient if you feel comfortable, right? So giving them the first word, it's a d. Is it a d? Is it a da? Maybe, oh yeah, it's a dog. It's a dog. Can you describe it? Does that help them? Some people also, in the reverse, they'll say, oh, I have one of these at home. I love taking him for a walk. That's a dog, right? They start describing it, and they're able to pull that word. Fill in the sentence. It's raining cats and dogs, right? Give them a choice. Can you model it? Repeat after me. Say, dog. Or same kind of cueing, but written. Maybe they're verbally not taking in that information, but you can write it down. All right, we did that already. But this is an example. Keywording. So let's say this was the menu for the day, and you're with your patient, and you want them to choose what they're going to have for breakfast. What are some keywords you would write on your board or your piece of paper, tablet, whatever you've got with you to write? Just throw out some words. You've got the menu in front of you. What would be the title on your keywording? Breakfast, exactly. Yeah. Let's see if I can erase this. All right. What would you write under breakfast? Egg, yeah. Oh, Hawaii. It's all in Latin. I hope you guys are well versed in your Latin. Yeah, eggs. Cheese, yeah. You could write ham and cheese. Hawaiian breakfast, I don't know. I think when I go to breakfast in Hawaii, it's usually pork and rice. That's it. If you needed them to pick the menu for the whole day, you're going to do it step by step. So you're going to do breakfast. I want a Hawaiian breakfast. I want pork and rice. I'm going to change the page. Okay, let's talk about lunch. What do you want for lunch? And you're going to break it down into each one. You're not going to give them all the information at once because that's probably going to be too much at that point. So cognition, communication, we're still talking about the ICF model. We're talking about buy-in. What's personal to them? What do they like to do? What's their job, right? And if you can structure your activities around that, all the better. So moving into cognition, right? I thought let's talk about memory for a second because this is going to affect any therapist, really any medical professional, right? If we're hoping that they're carrying over that information, we have to know what's going on with their memory. There are multiple steps to your memory. So first, I have to take in the information, right? I have a piece of paper in front of me. I'm processing it. That's encoding. That's also the point where my brain is saying, this is important. I need this. So, for example, think about when you were in school and you were in class. And if you weren't paying attention, did you remember that information later? No, right? So that first step, if they're missing that, and that's very much related to attention, they're not going to be able to carry that over later. Or you're going to come into their room and say, we did this yesterday, remember? And they're going to say, no, right? Because they didn't even get to that first step. Storage, part 2. I'm saving the file. I'm saving it to my desktop, right? I'm saying, I need this for later. And then I have to be able to come back and say, oh, I remember where that file is, right? So your memory can go sideways, go badly at any of these stages. But if that first part isn't happening, the encoding where your brain is saying, this is important, I need this for later, it's not storing and it's not retrieving, right? So that's kind of the first place we need to start thinking about is my patient attentive enough to even take this in for later? If it's novel information, right? If we're talking about something like a procedure, that's a little bit different because they already have that information in their brain. They already know how to stand up, right? It's just now we have to add those other parts. So if you're assessing cognition, right, you might need to say, oh, they're having trouble storing information. But regardless, if you're assessing or treating it, you can start recognizing what's happening, right? Can they recognize the information? Do they say, oh yeah, I think we did this yesterday? Well, that tells you they did encode it, right? Maybe they weren't able to say, oh yeah, yesterday we worked on sit-to-stands, but when you start to say, oh, let's do a sit-to-stand, they say, oh yeah, that's the one where I have to put my nose over my toes, right? Oh, okay, they've got it. They just needed a little clue. Are they recognizing the information with the cue, right? Or not at all, right? So if there's no recollection, the encoding was bad. If they don't recognize it, but a clue helps, they stored it, they're just having trouble getting back to it. So, how do we hack people's memory, right? How do we make it easier for ourselves as therapists to train something new? Has anybody ever heard of this term, spaced retrieval? No? Okay, so the idea is we need a lot of practice to remember information over time. Adult learning theory tells us we need information 6 times before we learn it and understand it. 6. How many times in adult life do we get information 6 times? Not often, right? Somebody says something to me, I say, I'm sorry, I forgot what you said. What did you say? Maybe they'll say it one more time, and then the 3rd time they're gonna say, forget it, never mind, right? And we're gonna get frustrated. But we actually know we need a lot of repetition. Think about school when you were a kid. You'd have class, you'd have homework, you'd go back to class, you'd learn about it a little bit more, you'd have homework again, and then you'd had a test that you had to study for. And guess what? The next year you went back to school and we talked about it again. That's why I remember the Pythagorean theorem 20 years later, even though I haven't used a squared plus b squared equals c squared in a very long time, right? So this is what spaced retrieval is going on. We need the practice. We can use this for multi-step things, but we have to make sure that that person's attention and encoding is at least semi-functional. So screening is showing them a picture and saying, this is Bob. Who is this? And hopefully you say Bob immediately after. And in a couple of seconds, I'm going to come back and say, who is this? Bob. Good, right? And you keep building how frequently you're coming back to that information. You can use this with anything. So my example is, when you see your mom calling and the screen pops up, you're going to press the green button. When your mom calls, what button are you going to press? The green button. Mom might be watching. We're saying the green button, guys. Yes, right? That's it. And then I'm going to come back in 15 seconds. Hey, your mom's calling. What button should you press? The green button, hopefully, right? If they don't remember that, we might have to start building in some cues, right? Mom, you could give them a picture like this. Hit green. Draw an arrow, right? Put that on their table so that they see it next to their phone. As a therapist, if you're in there with them for an hour, you can do this a couple times. So you're going to do it at 30 seconds, right? That initial first minute, and then maybe come back in 5 minutes. Do they have it? Great. Come back in 20 minutes. They still remember they should press the green button when mom calls. Let's say at 45 minutes at the end of your session, you ask, I don't know, the red one. I don't want to talk to my mom. You know that that's where their memory gap started. Somewhere between those half an hour to 45 minutes, that's where things started to fall off. So that means they need more reinforcement. Does that make sense? So everybody has a piece of time frame where information starts to get a little bit more fuzzy. So something like a stroke, where the body's already devoting a lot of energy to healing. Little things like this, the brain's going to say, I don't need that. That's not important. It takes energy, right? Yes, of course it takes energy. But in hindsight, when you have to backtrack a million times, right, it takes more energy. So it's kind of like the brain's taking a little shortcut to save more energy, but in the long term, it's going to make your life more difficult. So we really need a lot of that repetition. Let's say you come back tomorrow and you say, hey, your mom's calling. What button should you press? The green button. Great, right? They're starting to encode that information and they can retrieve it, right? But let's say I just asked them and I didn't show them the phone. And I said, yesterday we looked at your phone. What do you do when your mom calls? And they're like, I don't know, I have a phone. You could pull up the screen, have their mom call. What should you do now? And see if they remember the tactile, right? Okay, I have the screen, I see the picture, I recognize this, right? So you can just verbally prompt them to see what they remember, but you can also give them some clues along the way. Because if they have the clue and they remember it, that means they've got it. How are we doing on time? Yeah, okay. So, building on spaced retrieval, we need repetition, but the repetition needs to be correct. So, coming back to that learning, if you don't know, don't guess. Because if you guess the wrong thing, you have still reinforced it, right? We've all experienced this in our day-to-day life. We have students coming in and out of our clinic all the time. I'm terrible with names, right? So if I see our new hand therapy student, and her name is Brittany, and I see Brittany every day, and I say, good morning, Brittany, how are you? I remember that because I'm getting the repetition. But let's say I see Brittany today, and I see her again in 2 weeks. I'm like, oh, I think her name was Brianna. Well, I just reinforced Brianna. Her name's wrong. That's not it, right? But my brain already went down that pathway and said, oh yeah, her name's Brianna. even if I correct myself, next time my brain's going to want to go to Brianna because that pathway is already established. And it's going to take so much more work for my brain to say, it's not Brianna, it's Brittany, right? Same thing with your patients. If they don't know, don't let them guess. Because if they're guessing the wrong thing in a procedure, they're still reinforcing it, and it's going to take much more work to undo that. So minimize guessing. If they can have an educated guess, great, that's okay, but you need high amounts of correct practice. So you're applying this to your transfer training, any kind of movement, right? If there's multi-step and they're saying, oh, I think I need to I'm stepping my right foot, right? No, you're stepping your left foot. Let's try again. Left foot first, what are you doing? Left foot first, and make them do that, right? So simple, try to avoid allowing patients to make mistakes, and you're going to see, right, if somebody is impulsive, it's going to take more practice, and you're going to have to say, slow down, think about it. What did we do the last time, right? It's going to take a lot of practice, but you can apply this to almost anything you're doing in therapy. There are some examples online, too, if you guys are interested. All right. It's probably familiar to most of you in the room, yeah? Sit to stand. So, scoot forward. Make sure your feet are tucked back. Nose over toes. Push off the chair. Yeah? Pretty familiar steps? I'm going to steal a chair. Oh, no, I have one here. I'm not going to steal a chair. Who wants to be my patient? Pen, will you be my patient? Come be my patient. Okay, go ahead and say it, yeah. All right, so we're going to work on standing up, okay? So I'm just going to tell you the steps. Sorry, this is going to be even better. I'm going to show you the steps, and then you're going to do it with me, okay? So I'll show you, and then we're going to do it together. Scoot forward, feet back. We would have arms, hopefully. Put nose over toes, push off. Yeah, let's try again. What's the first thing you're going to do? Oh, you want to, did you want to stand or scoot? Yeah, stand is the last step. Nice job. So if you sit down, again, can you tell me if I'm doing this correctly? Was that right? No, right? What step did I miss? Uh-huh. Yeah, I needed my hands. Nice job. Yeah, and push off. Right? So errorless learning, you can have them be the judgment if it was correct. Great, sit to stand. So you can use lots of different kinds of cueing. It doesn't have to be just verbal. There's also the judgment piece. Thank you. Thank you, thank you. We're going to practice a little bit more in co-treatment so we can all do it together. All right, so coming back to cognition, right? What are our goals? Lots of different things. Running from safety all the way to those higher level social cues like pragmatics. There's a lot of nuance in these, right? So we're talking about neuroplasticity with stroke, with brain injury, right? There's really two approaches. We have task training, and we're going to talk about and do a couple different types of tasks that we can do for cognitive therapy. But we also really want to be trying to teach them strategies that are going to help. Because if you keep doing the same attention task over and over, they're just learning that task, which is helpful for certain things, right? You want them to remember how to answer the phone, remember their medications. Great, yes, that's task specific. But there are a lot of things in our day-to-day that are not. And we need them to be able to generalize those skills. So as you incorporate more and more cognitive therapy or dual tasking as a physical therapist, you want to make sure you're changing it up, because otherwise they're just learning that one task. This is where functionality comes into play, right? Because if we are thinking about task training, then we need to pick something that they're actually going to be doing day to day. This is back to the pyramid. Energy, we're going to talk about pacing. How do we train their attention? Whether that's attention process training, that's a program that you can buy. I showed you guys in the stroke rehab the Blaze pods, which are visual attention. You can use as physical therapists, making them do math problems, increasing distractions. Memory tasks, remember a list, remember a phone number. Watch a video and tell me what you learned. And then, right, what are those strategies that are going to help them remember information? Can they write it down? Do you need them to repeat it a bunch of times? Are they visual learners? Do you need to show them pictures or have them imagine it? Executive functioning tasks like med management, scheduling, or language tasks. Read a menu, list off as many different fruits and vegetables as you can think of. Add to the category. And again, strategies that are going to help them get to that word. So there are plenty of things we can do, and you can mix it up, but you kind of want to think about what's that underlying, I'm going to back way up. There we go. What's the main issue? Because I hear all the time, I have a memory problem. And when we get down to it, they have an attention problem. Their brain can't stay focused on the information long enough to even remember it for later on. So it's okay to play around with multiple domains, multiple kinds of strategies, but really getting at the heart of what the problem is. So let's talk about energy. Energy is a problem in stroke recovery. How many of you have patients that are just fatiguing very quickly, or they're saying they're tired all the time, right, in the longer term recovery? So as a cognitive therapist, I'm talking about pacing cognitively, but I have to think about the interplay between cognition, physical exertion, and emotional exertion, right? So we love to think about it being separate, but it's really not. My job is not physical. I have an office, and I sit most of the day. I walk 30 feet to go get my patients from the waiting room. I'm tired at the end of the day, right? Because I'm emotionally and cognitively pulled all day, right? The same thing is happening for our stroke patients, but that threshold might be much lower. So we need to talk about resting before they're really tired, right? Most of us will go and go until we can't go anymore, right? And what happens when we push past that? Patient's exhausted. They're crying, right? They can't reason through things anymore that they could do half an hour ago, right? That's a really hard thing to train people, right? So as a therapist, especially in the beginning of acute stroke recovery, you're going to have to cue them. Take a break before they're starting to suffer in their performance. As you get a patient that becomes more and more high level, they can use metacognition to think about what's going on. What does it feel like when you're tired? Are you thinking slower? Do you need more repetition? Are you having trouble thinking of words? Are you more irritable, right? Because then people can start kind of cueing themselves. Oh, I'm having trouble communicating more than I normally would. I need to take a break. Break is not sleep. Can be, but we just need them to do something that's restful. So mindfulness, meditation, deep breathing, close your eyes, listen to some music, or go somewhere quiet. Get outdoors, right? Spend time with your pets and your loved ones, whatever it is that's restful to them. There's not one correct answer, and they can switch between, but you want them to do something that's actually restful. What's not on there? Cell phone, television, because your brain is still processing all that information, which when you're cognitively really tired, it's not a break. Anybody ever heard of task cycling or the Pomodoro method? This is really popular in the United States right now. So they're really productivity methods for keeping your brain and your body attentive. But we can absolutely use this with our patients, and I do all the time. Switch between tasks. Do something that's cognitively demanding, and then do something that's physically demanding. And switch on and off. Give it a time frame. 15 minutes cognitive work, 15 minutes physical. Then we're going to take a break, and then we're going to loop back to that. A lot of us naturally do this, right? We'll write a couple notes, and we go get a cup of tea, and we come back and do a couple notes. So physical can absolutely be exercise. For my work, when I do this, it's I go make a copy. I print something off, I get a cup of tea, right? I put things away in my office. It's not exercise, but it's still a break from me typing and staring at my screen all day, right? These are easy things to try to kind of give your patients more energy throughout the day. It's also something to think about with your therapies if you're going back to back, is how can you create more of a switch so it's not all physical demands and then all cognitive demands. Compensatory strategies, things that we all do naturally and don't necessarily think about. These are basics, right? Memory, we talk about the acronym RAP. Write it down, repeat it, associate it, picture it. The more of these strategies a patient can use, the more likely they are to remember it. Attention, make them say things out loud. Do one thing at a time. Manage those distractions. And word finding, we're going to practice those a little bit in a second. All right, so what do you do with that patient whose insight isn't the best or they're impulsive? Goal attainment scaling. Make them plan it out beforehand if they can. Goblin Tools is an AI website. It's also an app. It's free. Highly recommend for your higher level patients. It's going to break the whole task down for them, and you can be really complex. It's a very good tool, and I've tried it with a lot of patients, and it seems to be accurate with every single thing we've tried. You could say, I'm moving to Thailand, pack up my 4-bedroom home, and it's going to break it down for you every single step. Strategies like stop, think, plan, and do, and effort gauging. These are all going to help your patient slowly start building that awareness of how they're performing. So we're going to practice this a little bit, right? Task analysis. I'm going to have you do this sit to stand. How difficult do you think it's going to be? How much help do you think you're going to need? You have them right. Scale of 1 to 5. 5, you're totally independent. 1, you need help with every single step. You don't need them to worry about the cueing levels, right? They do it. Okay. You said you were going to do it totally independently with a 5, but I had to give you a couple corrections of where you put your feet and that your hands had to push you off the chair first. So where would you put yourself? Right? Same thing. Oh, yeah, I guess it wasn't a 5. I guess it was more of a 3 or a 4. That's it. Start building that insight. Make them write it down or write it down for them so that way they can see and say, no, I said I was a 2. Right? Have them write it down so it's there, especially if their insight is pretty poor. Again, task breakdowns. This is going to be for a higher level patient that's out in the community. Make them think through all the steps before they actually do it. Similar strategy. When we're talking about cognitive exercises, cognitive tasks, same thing we're going to talk about with physical therapy, we need a certain level of challenge. So scale of 1 to 10, 10 being extremely difficult, challenging. You want to be about a 7, 5 to 7. 50 to 70% effort. If you're counting accuracy, that's also what you're looking for. You want your patient to be 50 to 70% accurate. If they're 100% accurate, 80% accurate, it's too easy, right? They're not learning at that point. And if it's a 10, well, maybe they're still learning, but they might not be very motivated to do it at that point, right? So 50 to 70% is kind of our sweet spot. Again, if we're talking about somebody who has that metacognitive ability to check in with themselves, how are you feeling when you do this task? Check in 5 minutes. Are you getting a headache? Are you getting tired? They say, no, I'm good. Okay, let's keep going. I'll check in again with you in 2 minutes. And keep checking before they get to that point of exhaustion. All right. So I'm going to give you all an attention activity. This is something I would do with my patients. I'm going to give you a sentence. I want you to put the words in order. I'm going to give you some words, and I want you to put them in order so that the sentence makes sense. So if I said dog the walk, you're going to say walk the dog. Okay? So your first sentence is, am I here? That actually makes sense, but could you reorder it into something else? Here I am. Good. Door, close the door. Out, let's go. Let's go out. How easy is that? Where's your scale? Was it a 1, a 2, 3, 4? Did that feel pretty easy? Yeah, right? Probably a little bit too easy. So maybe I need to give you 5 words. Bank works Mark in A. Mark works in a bank. Yeah, took a little bit more effort, right? Would you say that was 50% effort? Yeah, you'd say that's 50%, right? So that's where we would stay. If that keeps getting easy, put in a distraction. Turn on some music. Make them do something else while they're doing that. I could make it totally different. I'm going to give you 3 numbers, and I want you to add 3 to each new number. So if I say 5, 12, and 2, you're going to say 8, 15, 5. Yeah? All right. Here's yours. You're adding 3 to each number. 0, 22, 1. 3, 25, 4. Beautiful. That was quick. That might have been a little bit too easy for you, right? So then I could add another number. Again, I can add background noise. I could say add 3 and put those numbers in order. That's an attention task, right? It's verbal attention. You could make them do it visually if you're working on visual attention. So you want that nice spot of where they're not getting everything accurate and they're not super quick with their responses. All right. That's going to be one of the last things we do. Word finding. So let's say your patient's trying to communicate with you. They're having trouble getting that word. Things we can do. Give them extra time to think of it. It might feel awkward to stop and wait for somebody, especially if it's more than a couple seconds. But most people, if you give them a delay, they can think of the word. Have them describe it. Can they think of something similar to it, an association? Can they think of a similar word, a synonym? Can they think of the first letter? Can they gesture it? Can they draw it? Can they look it up on their phone? Can you come back to it later? They might remember. So let's practice. All right. We've got our lemon, right? How'd you describe a lemon? It's sour. Sour and yellow, yeah. That narrows it down. Pretty. It smells, yeah. Good, right? If I just said it's a fruit, not super helpful, right? I need more detail. Oh, it's a yellow fruit. A little more helpful, but there's still a lot of yellow fruit, right? So they have to practice giving a description that's going to help the listener get to it fastest. All right, we have our lemon. What's associated to a lemon? When you hear the word lemon, what else do you think of? Lime, yeah. Lemonade, tea, whatever. Good. Is there a synonym? Is there another word for lemon? Not that I can think of. What's the first letter? L. Yeah, there you go. How could you gesture a lemon? Yeah, small. Think of like squeezing, or you have a lemon juicer. Yeah. You could draw it. Oh, it's a fruit. It's sour. It's in the grocery store. They're usually pretty cheap. they're waxy, they're really shiny, right? That's narrowing it down. That's it. These are simple, and I think a lot of us naturally use this, but we can employ it with our patients when they're stuck so that they feel more successful. We are going to come back to more of these tasks in a little bit when we do our co-treatment, right? I'm going to have you guys do one more thing. This is going to be our last thing. All right. I'm going to give you a list of words. I'm going to give you my grocery list. It's 5 things. I want you to remember it. And I'm going to ask you again in a couple minutes, okay? On my grocery list, I need to buy lemons. I need to buy bananas, lettuce, some chicken, and milk. I'm going to tell you one more time. Lemons, bananas, lettuce, chicken, milk. All right, so I heard some people repeating it after me. Were any others of you using a different strategy to help yourself remember it? You were counting? Yeah, that's really good. With your fingers, yeah. Anybody else use any other strategy? Writing it down, yeah. Did anybody imagine those items? Yeah, me too, right? I'm visual. If I'm going to the grocery store and I have a list, I remember everything I'm going to pick up. These are strategies that you might have to use with your patients, and you're going to have to cue them to do it because they're not automatically doing it anymore. Maybe they used to be pretty visual, but since their stroke, they're not using that. You're going to have to figure out what helps them. You can use this with a transfer. Okay, I want you to imagine the steps before we do them. I want you to write down the steps, whatever it is, right? Because it works for you doesn't mean it's going to work for them and vice versa, right? We're just looking for a strategy that works for that patient. You might have to get a little bit creative. All right, what was on my grocery list? Lemon, banana, lettuce. You guys passed. You don't need speech therapy. Nice job. Okay. That's it, guys. We did it. Any questions? Any questions before we
ถาม
take
ภา
a
ษา
break?
ไทยก็ได้
Yeah, so-
นะใครอยากถามภาษาไทยไหม
สวัสดีค่ะ ถามจากออนไลน์ได้นะคะ ทางบ้านสามารถพิมพ์แชทเข้ามาได้นะคะ This is online
I don't know where the camera is. Hi.
Here.
Any questions? And if you guys are feeling shy and asking in a group, you can ask me one-on-one later.
And can I ask about space retrieval training?
Mm-hmm.
Yes. Like, how about criteria of patient that choose to use this technique?
Any patient. You can use it with any patient. So it doesn't have to be stroke. You can use it with dementia patients. But you're going to see, right, if they're not recalling it after the 5-second delay or immediately after, then you might have to write it on a piece of paper and you can use those cues. But if they're not remembering with that, it's probably not the best moment to be working on spaced retrieval, and you might have to back up more to attention. Does that answer your question?
Yeah, so that means like at least the patient should be like can recall after 5 seconds. It's be better.
Yes, definitely. Yeah, and so if they're not, there's like a little protocol on the bottom of that slide. If they're not meeting that protocol, they're not a good candidate for spaced retrieval yet. But
Thank you.
you're welcome.
And
Okay.
okay.
I have a question. So, if we train the patient who have a facier and also they're not like English or Thai that we can speak, like Arabic that we experience a lot. So, do you have any technique to help us to guide with those patients?
As far as communication goes, Google Translate is your friend, the internet. That's the hardest, right? If you don't have an interpreter or family member there, that's present. That's when that multimodal communication, I think, also comes into play, is like showing them pictures, using maps, those kinds of things. But you might need to rely more on visual information and pictures than spoken language, right? It's,
So
you know,
more visual photos and
simple,
things like-
visual. Yeah, that would be my suggestion.
Okay, thank you.
You're welcome.
So I have a patient that he's like geriatric with like anxiety and depression disorder, and he also have like a memory problem. That when I give him instruction that okay, when you go home, you can go up and down 10 steps with the stairs, something like that, and he can in the next session he cannot really remembering it. Do you have any technique with like people who have like this kind of psychiatric problem with memory problem?
Yeah. I mean, that's difficult, right? Because the two feed into each other. If you're depressed, you tend to have cognitive changes, and if you're cognitively impaired, you have usually mood changes. So that's a home exercise that you're giving him, the 10 stairs. Are you sending him home with like any piece of paper that says that? That would be my suggestion. First thing is just make like a visual aid. If you have multiple people on your team, I often make like an exercise sheet, and super simple, 10 steps a day, 5 sit-to-stands, whatever it is, right? And they can go through, check, I did it, and then have them bring it in. Yeah, that would be my first go-to, is make a visual checklist. Any other questions? Online? In person?
Online, no question.
Yes.
Okay. My colleagues have a question that if you have the patient who had the sensory aphasia, did you train or not? Or
That I have a sensory aphasia?
yes,
He can talk, but not.
don't understand.
So more like a Wernicke's type thing, what to do for that, yeah. So as far as the communication, written is really helpful. Speaking and writing, keep it super, super simple. And there's actually a structure, it's called Hubbard's cueing hierarchy, which I think you should have that aphasia presentation. I don't know if you guys got what we had with our stroke rehab, but there's actually a cueing level to work on for auditory comprehension. There's not a lot of research-based auditory comprehension protocols, unfortunately. So a lot of what we do is working up this level of like, can you recognize a word in 2 pictures, right? So I show a picture of a lemon and an apple, and I say lemon, right? Start building that way, but pick something functional. There's also considering some people have a harder time if it's the same category, right? Because I showed them 2 fruits, but if you show him a car and a lemon, you say, which one's the lemon? That might be easier, right? And you gradually work it up. Now you're going to put it in a sentence or a phrase. Then you're going to have a story about a car, right? Those kinds of things, and gradually working up. I would use written information as your backup in the meantime, though. AAC, images, right? Maybe it's that written part that's more difficult than the actual understanding of what an image is. I'd also say check their hearing. That's a big thing, right? Even if it's mild, right, at that point, when they already have so many other cognitive and communicative demands on their system, the hearing loss can make it a lot more complex. Yeah. Any other questions?
Can I ask another question?
Of course.
Like about cognitive pacing. If about the cognitive and physical switch tasks, do you have the time to recommend like how long to cognitive tasks and physical tasks?
So for my patients that are out in the community, I usually say 15 to 30 minutes. You're going to, in acute care, have to be the gauge, and you'll start seeing, right, where their stats start changing, right, where their accuracy starts changing. Let's say 10 minutes was where you noticed it. Drop it down to 5. Is 5 okay? Good. All right, next time I'm going to try 7 minutes. Let's see that. That way you're gradually building up. You're stopping before you're getting to that 10-minute exhaustion point where things start going a lot worse, but you can still push them a little bit. Yeah.
Thank you.
You're welcome.
Component to drive neuroplasticity. So the brain network, when we think of the neurons and the receptors and the neurotransmitters, we know from research that when we combine exercise and the working memory and the cognitive strategies, that neuroplasticity is increased and that potential for learning is increased at that time as well. So we're wanting to kind of introduce something that we feel is really beneficial. It's not possible always to do the co-treats, speech and PT together, but sometimes we can dovetail those so we could have PT and then followed by speech therapy. So we're going to run through a scenario with our patient that we have. So our patient for our sample is a 60-year-old with having had a right middle cerebral artery CVA who has left-sided weakness, 2 months post-CVA and being seen in outpatient twice a week. So the deficits of the patient, so cognition, poor insight, difficulty with planning, difficulty with working memory, flexible thinking, reasoning, some trouble with complex thoughts, speech, mild aprosodia, and reduced breath support, and then the physical deficits, foot drop, difficulty navigating obstacles, upper extremity and lower extremity weakness on the left side. So no major comorbidities, and our patient has a 2-year-old grandson. So his goal is to be able to take care of and play with his grandson on the floor. He's an engineer, and in his free time, he travels abroad with his partner. So
we are going to request one person from our audience that doesn't mind being a patient demo for us. And we just request that this person has good knees and doesn't mind kneeling, and also doesn't have any cardiovascular comorbidities, because we are going to start you off on the bicycle. And we do have a little bit of chocolate left as a bribe. So can we have one person who is open to being our patient?
Who wants to exercise a little bit?
Don't all jump at once. Yay!
Yeah, go for it. Would you like your chocolate now or later?
Later, okay. Okay, so thank you so much. So as a physical therapist, we're going to start the session, and then we're going to demonstrate how speech therapy would come into that session to do the task part of the session. So as Andy mentioned, our first goal is to prime the nervous system, to get that nervous system ready to learn. So in order to drive neuroplasticity, we are going to start our patient on the exercise bicycle. You look very good for a 60-year-old male. I'll have you sit down on our bicycle. Okay, and you can bring your feet up into the stirrups there. We might have to scoot you forward a little bit. Okay. Oh, it's okay. Thank you, though. Yeah, I'll let you know. Okay, so our patient is going to start off. Oh, I don't know if there's actual power. We're going to pretend that turned on. Go ahead and you can start to pedal. Oh, will it let you? There we go. Okay, so in order to drive neuroplasticity, we are going to utilize interval training. The patient is going to do a short warm-up and then start to do intervals at a higher intensity. That intensity would be at 75 to 85% of the patient's maximum heart rate. Those intervals of quicker pedaling or higher resistance are going to increase the heart rate, start to stimulate the nervous system. We're going to supplement that by doing an interval at a lower intensity. So we might slow the pace or lower the resistance on the bicycle in order to have the patient's heart rate come down to about 40% of the maximum heart rate. By doing those intervals, we can spark that neuroplasticity in a smaller period of time. So we don't need to do the bicycle for 30 minutes, 40 minutes, an hour. We can get that drive and nervous system priming in a shorter period of time. So since we have a short period of time, we're gonna do intervals. Okay, so we did a warm-up. I'm gonna have you go at a quicker speed. So go fast, 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 fast. Go, 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 go. Everyone cheer her on, woo! Right now, her heart rate is going up. We're now going to be at that 75 to 85% for 30 seconds. Keep going, keep going, keep going. Almost there, 10 more seconds. Go, go, go. We'll give you a fan. Okay, 3 more seconds, go, 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 and recovery period. So the patient is still working. This is an active recovery. Right now, the heart rate goes back down to about 40%. We, of course, would be testing the patient, making sure we're knowing what their heart rate is, making sure we know how hard they're working. You can also utilize the rate of perceived exertion, that 0 to 10 scale, where I ask the patient, how hard do you feel like you're working right now? When they're going at the quicker intervals, we want them working at a 7 or 8 out of 10. When they're going at the lighter intervals, they can go down to a 4 or 5 out of 10. It can be much lighter. Okay, you had your 30 seconds of your recovery. We're gonna do another speed interval. So go, 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 fast, fast, fast. Or I could increase resistance, okay? You might have to do a little bit of both to achieve that optimal target heart rate, okay? Go, 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 faster, more resistance, go, go, go. 30 seconds of higher intensity at that higher heart rate. Great. And you can slow down into your recovery, okay? So that's an example of what we would do. We're not gonna make you do it for longer, but we would do that for about 10 minutes to prime the nervous system, okay? All right, wonderful. So you did your 10 minutes, your nervous system is primed and ready, those neurotransmitters are going. We can bring your feet down from the pedals there. All right, and we're gonna move next into our functional task. The patient is primed and ready for learning. A lot more learning can occur now that we've primed the nervous system. And now we're gonna have our speech therapist come in. And, okay, so Catherine, our patient is ready for our co-treatment session. Since our patient has some functional deficits where they have weakness on one side of their body, they might trip and fall. They have foot drop, they have weakness on that left side. Floor recovery is an important component of being able to function well at home. If this patient trips and falls at home, we want to make sure this patient can get up successfully and safely. The other thing that stands out to us is that this patient has a 2-year-old grandchild, and they want to be able to interact and play with that grandchild. So for those 2 reasons, our co-treatment, we chose floor recovery or floor transfers, getting down onto the floor, getting back up from the floor as our co-treatment, so that our patient can learn to be independent with getting up from the floor if they fall, and also tying into their goal of being able to get down onto that floor to play with their grandchild. Okay, so we are going to have our patient, actually, I'm gonna raise this up. So today we're gonna work on safely getting down onto the floor and getting back up from the floor, okay? Because I know you wanna play with your grandson. Okay, you know what, let's be nice to your knees. So first I'll demonstrate all of the steps that you're going to do, and then we'll break it down, okay? So I'll stand where you are right now. You are going to put your left hand on the surface here. You're going to take a forward step with your right leg. You're gonna come down onto your knee, come down onto your other knee. Both hands will go onto the floor. Then you're gonna lower onto your hip. To get back up, you come onto all hands and knees. Come up onto both knees. Hand will go back up on the bed. One leg comes up. We stand up, we make sure we're stable, and then we're up. Okay? Let's break that down piece by piece, okay?
And so this is what I would do, right? So we're going to do this exercise. What is it for?
Pardon?
Why are we doing this movement?
Because Because I want to play with my grandchild.
Right? Great, yes. And we would love you to do that safely. That's
Okay.
it, right? So you're already kind of prompting them to making sure they're understanding why they're doing this.
Okay, the
So
first.
do we want to ask it, how hard do you think this will be for you to do? I think it's so hard. So on a 0 to 10 scale, how hard will it be for you to get up and down?
Make sure you're talking into the.
I think maybe 7.
Okay, 7. Do you think you'll need help to do it?
Yes, of course.
Okay.
Because my left side is no power.
Your insight is
Good.
amazing
patient
for
has
right
excellent insight
side
for someone
stroke.
with a right-sided seizure.
Do you think you'll need a little bit of a help, or maybe a moderate amount, or a lot of help?
I think maybe,
What number would you give it?
I think 3.
Okay,
Okay.
very good.
Okay, the first 2 steps are bringing your hand on the table and stepping forward with your right leg.
Good. Nice job. Can you do that by yourself again? Start from the beginning. Hand on table, step forward.
Okay.
Nice.
The next step is to lower slowly onto your left knee and then bring your right knee down.
Yeah, you got it. Right knee down.
Oh, so you can bring that knee down toward the floor.
Mm-hmm. So both knees. So we're going to go hand on table,
Back up, bring your leg up, right leg up, and stand back up.
stand back up. There you go. So what I'm doing right now is because it's a multi-step task, we're doing like 1, 2, 1, 2, 3, 1, 2, 3, 4. This is going to depend on your patient's mobility, of course, right? You're doing amazing, so.
And remembering that repetition, right? So we want our patient to be reinforced with all of these steps for safety. But the patient's really focusing on the functional implication of, I want to get down to play with my grandchild. But we're also reinforcing these step-by-step processes so that they can learn. Okay.
All right, let's go through the rest of it.
Again. Right knee down. Okay. Now you can bring both of your hands down onto the floor and then lower onto your right hip.
There you go. You got it.
Very good. And you are here.
And so once they're down here, right, this is kind of like one half, right? So, you know, it's going to depend on what you're training the patient for. You can sit more comfortably if you want. Right, is it a quick get up and get down and get back up, right? I would recommend splitting it if you can, just to reduce the amount of information they're taking in. And the other thing that I know as PTs you do is you kind of give it a little, like, pattern, right? Foot, right? Hand, foot, step, down, right? Something like that. So that way they can start rehearsing it and just saying that each time they do the transfer and keeping it consistent. And if you can do it between therapists and keep it consistent, that's going to be even better because you're going to be reinforcing that same piece of information again and again. All right.
So I'm going to be your grandchild.
Yeah.
So we got you.
No.
We got you down here now, so we have some time to practice moving so that you have more repetition, so more learning. So what we call block practice of repetitions of the movements down on the floor. So what we're going to ask you to do is you're going to bring your right hand to the pillow. Good. And your left hand to the pillow, and then you're going to come back onto hands and knees. So stable base. Good. There you go. Good. So in this position, what I'm going to ask you to do is reach for the bear, and then you're going to move the bear to that spot. Okay.
So, sorry for me. My one recommendation in this case would be have them do the movement a couple times without
Before the moving.
Before
That
the
would be
bear,
better.
and then you can make sure they learn that task, and then make it even harder with Mr. or Mrs. Bear.
Okay. So now what you're going to do is place your left hand over by your knee on that side. Good. And then you're going to lower back down onto that right hip. Very good.
Yep.
Okay. So let's practice that one again. So bringing your hand and then coming up. Very good. Okay. So let's practice that to your opposite side. So bringing your right hand toward your knee on that side and then lowering your hip down. Good. And resting. How hard are you working on a 0 to 10? Is this pretty hard?
No, there's only 1 or 2.
Okay.
One or two, she said.
So here's our example of where we might, if it's too easy, we might want to try to find a way to make it more difficult for you since you're having not much of a struggle with it. So what we might try to do is change your vision while you're doing it. So this time let's practice you coming back up, and this time you're going to have your eyes closed, okay? So eyes closed, and you're going to place your right hand on the pillow in front of you. And you're going to start to shift your weight toward your right side, coming up onto your knees. And try to widen your base so you're more steady. There you go. Good. Did that change? You can open your eyes now. Did that change the difficulty at all?
Yes, of course, because I cannot see anymore.
Okay. So where would you rate it with your eyes closed? On a 0 to 10, it was a 2 for you with your eyes open.
3 or 4.
Okay, so we brought it up to a 3 or 4. So we have things that we could add in order to, again, make it more challenging. But I think we'll go to adding the other motor task rather than any kind of verbal or cognitive task. So in your position, are you comfortable? Are you okay there? Okay, so we're going to have you practice reaching for the bear. So you're going to be weight bearing. This is your weaker side. So you're going to be shifting your weight onto that side. And if it's too unstable, you can shift back a little more onto your knees and then reaching for the bear. Good, and moving it toward me. So that's actually a good way to break it down, is the reaching initially. Good. Very good.
What would be the little, like, words you would use to help a patient remember in this case, right? What would make sense? I don't know, right? Would it be hand, knees down?
Sometimes I'll ask the patient. So I'll say, I call this reach with left, but what would you call this? And they might come up with their own phrase or their own way of saying that. But I might say, reach with left, lift bear, place down. Reach with left, lift bear, place down. But the patient might have their own way of saying that. They might think of their grandson and think, bring bear to grandson.
Yeah, and my recommendation would be keep it simple, right? Reach left, bear down, reach left, bear down, something like that, right? So that way it becomes like a little song almost.
Okay. All right. So let's go through that. So let's try eyes closed. Okay. So reach left, bear. Okay. And down in my direction. Good.
Would you call
Release.
that down? How would you describe it? I'm sorry, we didn't get your name. Would you say down? Like, how would you describe moving the bear?
Down.
Yeah, you would say
Okay.
down. So reach left.
Reach left.
Bear down.
Would you call that down? Does that make sense to you to say down? Or would you say something else?
Maybe down.
Okay, yeah, as long as it makes sense to you, right? Because you want to be able to remember it for
Okay.
yourself. Yeah.
So you're sustaining this position for a long time. You're probably getting tired, so you can sit back onto your heels to rest. There you go. So, yeah, and use your arms for support if you want, but otherwise, yeah. If you're comfortable there, or you can stretch out a little bit. There we go. Good. Good. So this is just an example of we're doing repetition and adding a specific task and simulating what the goal is for our patient to be able to stay down on the floor and move comfortably and safely.
And the patient is concentrating on the action here. The patient is thinking, I need to bring this toy toward my grandchild, right? But we know this patient is getting weight bearing through that left weaker side. We know this patient is getting core stability by being in that quadruped position. We know they're getting a lot of good sensory information to their body by being in that closed chain position, right? So we understand that this task is way more complex, but that patient is really focusing on, I want to practice getting this toy to my grandchild.
Okay. Do we want to talk about the dual tasking with the same? Okay. So now if we wanted to increase their neural load, right? How much is their brain working? You said this was about a 3 or a 4. So it's still a little bit easy, right?
Our patient is very advanced.
I know. Yes. So, any ideas? How can we make this harder by adding a cognitive piece? And you can be pretty creative here. What else could you make them do? While they're working on moving the bear. Yeah, you could count numbers. How many times have you moved the bear? Absolutely. Yeah. Should we try the move it from side to side like we talked about? Okay.
Go ahead.
Right. So I'm going to have you come down onto your right hip again, because part of being able to be mobile on the ground with your grandchild is being able, oh, they're over there now. I'm going to have to come over this way so I can reach for them. Oh, they're over there now. Now I have to go over here, right? So we know we also want to work on that so that they can get up from each side. We don't know if they do have a fall, which side they're going to fall to. And their grandchild probably is pretty mobile, 2 years old. So we want to make sure they're able to do that task. So we might have our patient, go ahead and you're going to be on this side. We're going to say your grandchild moved over that way. So I want you to push back up onto your hands and knees. Yep, and then lower your hips down to that other side. Great. Every time you move over to that other side, you're going to grab that bear. Go ahead and reach for it. Oh, so you can stay down. Yep. Now reach for that bear. And I would also be being a better PT. I would guard it. It's too hard with the microphone. But so go ahead and reach for that bear, and I want you to pass it over to that other side because your grandchild is over there now. Great. Okay. Each time you shift your weight to the other side, you're going to move the bear to the other side. Okay, so those 2 steps, you're going to go up onto your hands and knees, lower down onto the other side, and then move the bear.
Great. Now when you do that, I want you to start counting how many times you've moved the bear.
Okay.
Mm-hmm.
Yeah, and move it onto the other side. Oh, hold on, wait. So what went wrong there?
Yeah.
Yep, you picked it up, but did we move it? Yeah, so there we go.
Move. Shift, move.
So let's pause for a minute. We're going to remember our steps of shifting, lifting, and moving, right? Okay, so shifting, lifting, and then moving.
Yeah.
You got it. And what number are you on? Shifting.
Okay, so I had listed some of those deficits. What do we think we're working on right now? Are we working on planning, working memory, flexible thinking and reasoning, thought synthesis? What's this task of switching and counting the bear? What cognitive process is that out of the ones I've listed? Any ideas? Yeah, working memory, right? It's being able to track a piece of information, manipulate it as it goes, right? So that's that ability to dial a phone number, right, while you look at it, or you remember that passcode that they send us for everything now, the 6 digits, and you can hold on to that just long enough to type it in. So that's what that is.
So I'm going to ask our patient again, how hard were they working? So they were doing that physical task, the motor task, the cognitive task. They were doing a lot at one time. How difficult was that, 0 to 10?
Okay.
It's 8, okay.
So we want to demonstrate that we're going to keep adding in or layering in challenges until the patient feels pretty challenged by this task. If we're only challenging them at a 3 or a 4, that's not enough to create that learning, to drive that neuroplasticity, to drive that change, right? We want to create new connection, create new connections in the brain. But in order to do that, they have to be challenged. So we want to get to that at least 7 out of 10 or 8 out of 10 challenge in order for that to be enough to drive that process. So if your patient is rating the task at a 3 or a 4, add in another layer to make it more challenging. Okay.
And
We
want there to be some errors, so we're looking for about 70% accuracy with the task and then 30% error. So if it's 100% accurate, then we need to redesign the task, that it's not providing a challenge for this patient any longer. So we're going to create a new design and change the task in some way.
And this is where you pull on your cognitive therapists, right? What are they having trouble with? Because that's an easy way to figure out what's going to make it harder, right? So let's say you said it was a 5. Now I want you to do the same thing with the bear, but while you're moving the bear, I want you to tell me how you would plan a trip for a vacation. Right? So now you're going to have to be doing all of those, right? And we would be working on that planning, thought synthesis, right? Putting everything in order. So you can use your cognitive therapist as a nice resource of, okay, how do we increase the complexity of this? And also, how do we make it functional to that patient so they're also working on those cognitive pieces that are difficult for them? Yeah. Yeah.
Okay, so for getting back up, we're going to do the same thing in the reverse. So I'm going to ask you, our patient, to go back onto their hands and knees. And you can use the pillow if you want for your knees. Underneath your knees. Yeah.
If you want.
If you want, yeah, be kind. Go back up onto your hands and knees. Yep. Good job. Awesome. You're going to go up into tall kneeling, so go up high. Do you remember where your left hand might go? Yep. Which leg will go forward? Up to stand. Go ahead and step forward. And then you're going to make sure you're stable before letting go. Okay. And then we might repeat the same process of repetition or breaking down that task on the way back up. Okay.
And then to promote that errorless learning, Angelina could just show in the incorrect order and say, did I do that right? Right? Does this look correct? Because there's going to be that self-judgment of, was that actually the steps that I was supposed to be following? So part of, like I said, errorless learning is being able to judge the errors in other people or yourself. If people have poor insight, videotape them. That would be my recommendation. And if you can, show it to them. Say, look what you did here, and let me show you how I did it. What do you notice is wrong? That's an easy way. Because if you can't see yourself, sometimes it's a little bit harder to gauge what you're doing.
So the last thing we'll ask of our patient is to reevaluate and see how much assistance did they end up needing. Can they rate on that scale from 1 to 5? How difficult was that task, and how much assist did they need? So we'll come back to that question that we asked them at the beginning. So we're going to have you look at this scale from 1 to 5, and I want you to tell me, how did that go? How would you rate that on a scale from 1 to 5? Did you need help? Did you do it independently?
You're 5. You're totally independent. I can see why you would say that, right? Because towards the end, you did it on your own. But every once in a while, Angelina had to give you some cues, right? So I would say maybe you were more like a 3 or, yeah.
But that's a great conversation to have, right? The patient rates themselves, the therapist gives them a rating, and you talk about why. Okay? So that's helping to draw that insight in for that patient. Okay? Let's give a big round of applause for our volunteer. Please take some candy. There's some candy there.
Hey, don't forget your chocolate. Your pick. You're welcome.
Okay. Any questions about co-treatment or about some of the things you observed?
Oh yeah, sorry. You can mix it that too. Oh yeah.
Any questions?
Online, in-person questions.
So, do you already have a session that the speech therapist and the PT will join together in one patient?
In our clinic, that is not an option. We just don't have the kind of scheduling set up to do that. So that's where we're pulling really information where I can then say, this is what I see with the patient cognitively. These are the strategies that are working. Or you need to repeat something to them 3 times to remember it. And then you can just use those strategies in your session if you can't work on it together. Yeah.
Yeah, there's still having that carryover can still be beneficial. Ideally, we would have an opportunity to do more of those hands-on simultaneous sessions. But if that's not realistic for you or realistic for how your day-to-day goes, that's okay. You can still, as Catherine said, we can still carry over those strategies. So during my PT session, I could remember to state those simple verbal cues for each section of that transfer. Yeah.
So was it clear our reasoning for why we might do the co-treatment, what it would change for the patient? So what kinds of things might it be beneficial for if we're working together?
Is it too difficult for the patients if we bring different objects, many different objects, and command the patient to choose the right one? Too difficult if...
It depends on the patient. Absolutely. Yeah. For some patients, that might be a really good strategy. And then if they have aphasia, you could also be working on that receptive language. But no, I would say that's a really good option, making it more difficult. It just, you have to gauge on how accurate your patient was before. Yeah.
Absolutely.
Yeah. Exactly. Exactly.
Right. So just again, building the neuroplasticity, building the growth factors in the brain that helps the patient to learn more in the single session and have more challenge. So we're trying to grade the challenge for the patient so they get the most benefit out of every treatment. And then they see themselves improving, so they have rewards in their neurotransmitters, their dopamine, because they see they're more independent, they're rewarded by their success, and then that helps them to be able to move on to a more difficult challenge the next time. So in a follow-up session, doing the transfer again, but having it become more automatic by adding the planning. So while they're doing that, they're telling you about their plan for the trip to Australia. And that makes that whole movement more automatic, and they don't have to think so hard about it.
We also want to make sure that what they're practicing with us in the clinic translates into their home environment. So if they have a noisy environment, maybe they have many people living in their home, we might want to perform that same task, but instead of doing it in a quiet, isolated space, maybe we do it in a crowded area. Maybe we take them to the middle of the gym in the middle of the day when there are a lot of people and conversations going on. So changing the environment can also be a way to layer on an additional challenge for the patient and help that translate into their home environment. All right, very good. Well, we will move onward, but feel free to ask any additional questions that you may have. And I'll use you as my patient.
Yeah.
That's okay. Okay, so we're going to move into PT assessment and treatment, and we're going to focus first on ataxia. Ataxia is a challenging thing that it's not often known how to assess it and how to treat individuals with ataxia. This will be a bit of review for those of us who were with us in Portland in July, but it's a good topic to discuss. These are some resources: the Stroke Engine, the Shirley Ryan Ability Lab, and the Stroke Edge documents that have outcome measures that are validated in the stroke population. They are updated on a regular basis. They have the numbers for the minimal detectable change, so you can help write your goals for your patient. So these are just resources I wanted you to have a whole list of comprehensive assessment tools for patients with stroke. So we're going to focus on the SARA first. So the SARA, or the scale for the rating and assessment of ataxia, there are 8 different things that we're going to assess, and the score for the SARA is a 0 to 40. The best score is a 0, because if our patient did not have ataxia, they would score a 0. Okay, and a 40, a high score, is the most severe ataxia. So if they score a 40, they have very significant ataxia. Okay, the first 4 items are scored as a whole, and the second 4 items have a left and a right component. For the left and the right component, we score each side separately, then we add them together and divide by 2. Okay, and we'll talk about that again as we go through. So I'm going to ask my patient, Catherine, to come with me here. So the first item, and those are links to the SARA, so you can pull it up if you wanted to have the outcome measure in front of you. I know each of the items very well, but I do not have every single one of the qualifiers for the scoring memorized. That I always look at in order to score. Okay, so don't feel like you have to memorize it. You should know how to test it, but it's okay to watch the quality of the movement and then score it with your score sheet. The first item is gait. So I'm going to have my patient stand here facing that direction. And I'm going to say, Catherine, I would like for you to walk down just before that table. And when you get there, I'm going to have you turn around and face this direction. Okay? Okay. Go ahead. And we're assuming this is a 10-meter walkway. Okay, so you want to have them do 10 meters and turn and stop. Okay. The second part of the gait item is tandem walking. So our patient needs to walk heel to toe, and the goal is to do at least more than 10 consecutive steps. They are allowed 1 misstep, so they are allowed to go out to the side and come back in 1 time, and that can still be a full score. But if they aren't able to do those tandem steps, then that affects their score. Okay, so let's test Catherine out. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and more than 10 is 11. Perfect. So according to our score, Catherine was able to do the walking, no missteps in the tandem walking. She would score a 0. There was no evidence of ataxia in that number. If she had slight difficulties with doing the 10 tandem steps, that would be a 1. If she was not able to do more than 10 tandem steps, it's not possible for her to even get to the 10 tandem steps, that would be a 2. And then so on and so forth with the grading. If there's staggering involved with the turn, it's a 3. If there's marked staggering and they're needing support of a wall. So that's one thing I didn't comment on is you're going to perform this near a wall or near a surface. We just don't have a 10-meter wall here. Because if the patient uses that wall to touch base with as they're walking, that means they're going to be a 4, okay, because they need support of that wall. If there's severe staggering and they're needing support of an assistive device, so a crutch or a walking stick, they're going to be a 5. If they're not able to do it without strong support, so either 2 assistive devices, such as 2 crutches or 2 hiking poles, or a walker, then they're going to be a 6. If they need support of a person, if they need physical assistance, they're a 7. And then if they're unable to do it, even with support, even with devices, then they're an 8. Okay? Okay. So stance, item number 2. There are 3 components to item number 2, and we will ask for Catherine to take her shoes off. So this item is performed without shoes. And we checked to make sure she doesn't have holes in her socks. We all do, it's okay. So the first one is standing in a natural position. So we can have her stand with her feet in parallel. If she can do this for more than 10 seconds, full credit on that part of this item. The second part is feet together. So bring your heels and your toes to touch, looking straight ahead. I'm, of course, guarding my patient throughout this. If they can stand for greater than 10 seconds in this position, that's a full score for this component of number 2. The last one is full tandem, so heel to toe, holding that position for greater than 10 seconds. Catherine's able to do that, full score. That means her overall score is a 0. Okay, so no ataxia was demonstrated in those 3 positions. If she was not able to stand with her feet together without sway, so she had some sway, and she couldn't stand in tandem for greater than 10 seconds, then she would be a 1. If she had sway when she was standing with her feet together and couldn't stand in tandem, she's a 2. If she's able to stand for greater than seconds with her feet in a natural position, but not with feet together, she's a 3. If she's able to stand for greater than 10 seconds in a natural position, but only with support, so I mean needing to help her, or she's needing a little bit of support from a surface, that would be a 4. And then only with constant support would be a 5. She can't let go when she's standing in that position. And then unable to stand for greater than 10 seconds, even with constant support of an arm, that would be the full score of a 6. Okay? Okay. So I'm not going to go through all of the scores for all of the remaining items, but that was just to give you an idea of how you would grade each item. Okay, we'll run through the rest of the items, but I won't talk about each of the individual scores. Okay, the next one is sitting. So I'm going to have you sit on here, and I do have it high on purpose. I can lower it too. So the reason I don't have her sitting on a surface where she has back support or feet support is because we're looking for ataxia at the trunk. Okay, so you want the feet to be not to be fixed on a surface. You don't want the trunk to be supported for this item. For this item, I'm going to ask Catherine to extend both of her arms up to 90 degrees. Can you reach ahead? And hold there. We're looking for her to hold for greater than 10 seconds, and then we're assessing to see, is she stable? Is there any sway in her trunk? Does she need any support of an arm or support of a person? Okay, so you can read through those scores on that item, but that is how you would test it. Okay, so that's sitting. The next one is speech disturbance. How great to assess speech disturbance on a speech therapist. For this item, I don't necessarily do anything in particular. You're talking to your patient during your evaluation. You are listening to them speak throughout the whole time you're with them. It's a pretty subjective rating. There's not clear criteria. It says suggestion of speech disturbance for a 1, impaired speech, but you can still understand them. If you don't have to ask them, hey, what did you say? Hey, can you repeat that? Then they would be a 2. If they're occasionally difficult to understand and intermittently you are having to ask them to repeat, then they would be the 3. And then down to a 6. 6 would be unintelligible. You can't understand what they're saying. Okay, so that one's a little bit more subjective. Okay, the next one, I do want Catherine sitting on a stable chair. Sorry, Andy, I'm going to steal your chair. You can put your shoes back on. And here, I'm actually going to turn it to face this way, and I'm going to steal another chair. Andy, I'm going to steal your chair again. Oh, thank you. I'm going to put it facing toward. Thank you. Okay, Catherine, thank you. Can you sit down in the chair facing me? Okay. So if you have the scoring sheet in front of you, check this one out because it could be a little confusing. This is item number 5, the finger chase. This is assessing for dysmetria. Dysmetria is overshooting or undershooting from a target. Okay, we want to perform this test at about 50% of the patient's functional reach. So extend your arm out all the way. We want her to be about 50%, okay? And I'll explain why once we go into the next item. So first, no. Yeah, regular at first. Okay, for this item, I'm going to hold my finger out, and I'm going to say, Catherine, I want you to mirror my finger. So hold your finger in front of it. I'm going to move my finger, and I want you to follow it as quickly as you can, okay? Okay, I'm going to move my hand in random directions, and it should be at a speed of about 1 move every 2 seconds, okay? So here we go. 1, 2, 3, 4, 5. Okay, so that was a good score. Catherine was able to follow my finger. There were no overshooting or undershooting. We score based off of the final 3 repetitions. So the first 2, if she overshot and came back, and then she was able to follow for the other movements, that doesn't affect her score. She can still score a 0. Now, if in the final 3, she overshot and came back, and she overshot and came back, that does affect her score, okay? If Catherine is continuously overshooting or undershooting, we would grade that dysmetria based off of approximately how much dysmetria was present. So is she overshooting by 5 centimeters, 15 centimeters, or greater than 15 centimeters, okay? One thing to keep in mind is that if Catherine is consistently off to one side, so what if I move and she's over to the right side of where my hand is? That's fine, to one side. And then I move again and she's still over to that same side. And I move again and she's still over to that same side. Is that dysmetria? Is it? So dysmetria would be when they overshoot and then correct, or when they undershoot and correct. But what if she's consistently over to the side? It's the same every time. I keep moving, she's over to that side. Yes, beautiful. It could be vision. So don't get confused. That's a tricky item to score. It might not be dysmetria if vision is impaired. Okay, so if it is consistently off to one side, likely vision is coming into play. Dysmetria wouldn't cause that type of a demonstration. Okay, so only if they're overshooting and then coming back to the target, or undershooting and coming back to the target, that is dysmetria. Okay, all right. Moving on to number 6, the nose to, and then these are the items you would score each side. So we do that on one side, we would do that on the other side. Each side is scored individually. Then you add those scores together and divide by 2 to get your score for the Sarah, okay? Items 5, 6, 7, and 8 are all scored left and right sides, okay? The next one is the finger to nose test. This is item number 6. And this is measuring tremor. Tremor is displacement about a fixed axis, right? So not to confuse it with dysmetria, that's overshooting or undershooting, we have a center axis to our tremor, okay? So looking for that center axis, we want the patient to be reaching at 90% of their reach. Does anyone know why? Why would we not want to assess tremor with a more closed position? What might they do in this more closed position? Anyone? We might have to allow Catherine to answer.
It's easier to lock your arm in place and rest against your torso.
So you're stabilizing proximally, right? You're using those shoulder joint, those accessory muscles to help create more stability, and you could be preventing some of that tremor from coming through. Okay, so 90% for item number 6, whereas it was 50% for item number 5. And that's why it's important to distinguish between those 2 positions, because we don't want tremor to interfere with our dysmetria assessment, right? Dysmetria may still impact our tremor assessment, but we know to look for that displacement about a fixed axis, right? Okay, so I'm going to say, Catherine, I'm going to hold my finger here. I know I'm at 90% of her reach. Can you touch your nose and then touch my finger? Good. 4 more times. They're doing 5 repetitions, 2, 3, 4, and 5. Very good. So no tremor was seen there. Do a horizontal tremor. So I'm going to have her do that again, but she's going to demonstrate some tremor. Yep, and do like a, yeah. Yep, and keep going to nose, to finger. Yep, and nose. Okay, so she has some tremor there, right? We see some intention tremor there. We're measuring how far the amplitude of that displacement is. So I'm the center axis. She's displacing side to side from that axis. So I'm having to estimate, is that less than 2 centimeters? Is it less than 5 centimeters? Or is it greater than 5 centimeters? Or can she not even perform the task? Is it too great to perform the task? Okay. For that one, I'm having her move at a moderate speed. So if she's going very slowly, that can also mask some of the tremor. So make sure she's moving at a moderate speed. And make sure she's performing 5 moves or 5 repetitions. For this one, you're scoring any and all of the repetitions. You're looking at the quality for all of the movement, okay? And keep in mind, she might overshoot or undershoot. If I know from item 5 she has dysmetria, she might tremor over here and then come back to the target. But I'm ignoring that dysmetria component. I'm looking for the displacement around that fixed axis to grade number 6. Okay, any questions on that? Those are the trickiest 2 to grade on the SARA. Any questions? Y'all got it? Okay. Okay, the next one is much more simple. It's fast alternating movements. We're going to have our patient pronate and supinate quickly on their leg 10 times. I don't have to tell them this, but I'm secretly timing them because I want to see if they're able to do those 10 repetitions in 10 seconds or less. Okay. So Catherine, I'm going to have you do this, and I'll tell you when to stop. One hand. Good question. So one hand at a time. Don't test bilaterally. And does anyone know why we don't test bilaterally? Or simultaneously bilaterally? What can they do? What happens if they're doing it at the same time? Does that increase their learning on one side? Sometimes we use that as a technique, right? We might have them doing an activity with both of their upper body in order to improve the quality of the movement. So if they have a deficit on one side, they might mask it if they're doing it simultaneously. Okay, so we're doing one side at a time. So on your right side, go ahead and turn your palm up and down. Yep, 3, 4, 5, 6, 7, 8, 9, 10. Good, I hit my stopwatch. That was less than 10 seconds. She gets a full score for that one. Irregularities in that might be, right? That might be an irregularity or not going all the way. Okay, so you can always stop the patient and redefine the pronation and supination, have them test again, but no more than 2 trials because then there's the element of teaching and learning. Okay, and then last but not least is a lying down heel to shin. So I'm going to ask Catherine can you take one shoe off? Or both, it doesn't matter. I'm going to ask Catherine to lie down. The reason we have her lying down is so that she cannot see her lower extremities. If she is using vision to give her proprioceptive information of where she is, we don't want her to mask any deficits she might have. So we don't want her to see her lower body. So I'm going to say, Catherine, I want you to lift your right foot, and I want you to put your heel on the front of your left shin by your knee. You're going to draw a straight line down to your ankle and then place your leg back down on the table. Excellent. And now I want you to do that again 3 times. Good. 1, 2, 3. Okay. We have them do that on each side. And what we're looking for is, go ahead and put your heel on your shin, is if her heel is maintained to her shin, but she's deviating side to side, that would be a 1. Okay, if she's coming off of her shin, that affects your score for the 2, 3, or 4. Okay, so that's what we're looking for when we're doing the heel to shin. Is the path nice and smooth and linear, or is it side to side? Or is she jumping off of the target. Okay?
You'll see if they have a cognitive deficit and if they need to see OT.
Yes, the SARA is lots of multitasking. Okay, so that is the SARA. Again, that'll give you a good idea of how to quantify their ataxia. Ataxia can be pretty challenging to measure, so this is a good objective way of measuring their ataxia and letting you know where their deficits are. So we're next going to go into, oh, go ahead if you.
So just one more comment on the SARA. It takes quite a bit of practice to feel comfortable doing that assessment. So the website for the ataxia assessment has videos of this assessment being done on various patients. So you can go to the website and view the videos and score it yourselves and then practice in that way. But then also you can submit your responses and get a certification in the SARA assessment in doing it. And so that might give you just a resource if you want to see someone else doing it or get some more exposure to what that assessment involves. And I think seeing other therapists do it and then practicing it and scoring it would give you maybe more degree of confidence with that particular one because it's fairly complicated. So
I will say it took a long time for me to feel comfortable with the SARA, so if you're feeling similarly, that's normal. After scoring my first couple of patients with the SARA, I would chat with colleagues and I would show them, here's what they demonstrated, how would you score that? And that helped me to really learn and reinforce that I'm scoring correctly. But those resources Andy mentioned and getting to see that video can be helpful too. So we're going to move into treatment for a patient with ataxia. And the big things that we're going to keep reinforcing in terms of treatment for ataxia are that the patient wants to create these slow, small, soft movements. That phrase is actually one of our very own Andy's. And I love that statement of slow, soft, small movements. If we're moving too many segments at the same time, that doesn't tend to work well for our patients with ataxia. We really want them to think of smaller, controlled movements. We want them to have more closed chain activities to start, and that helps create more of the emphasis on core stability and then drawing out from the core out to the extremities. So the other thing we reinforce are helping the patient to recognize errors in their activity. So we're going to ask the patient, what do you think went wrong with that movement? How do you think you can improve that movement? And then help them to recognize the errors and address and state how they can correct the error. So we're going to demonstrate that in a moment. The first thing we're going to show are a patient with ataxia and how to do a transfer. And we're going to start with a squat pivot transfer so that we can, again, reinforce the principle of reducing some of those degrees of freedom and increasing the weight bearing through the extremities. So we're keeping the center of mass low, we're decreasing the speed, we're thinking of those slow, soft, small movements, and we're utilizing vision to help guide that movement. Do you want to be our patient for this one?
So one other comment on the ataxic patient, because they're overshooting so much all the time, and it's creating fear that they will fall, that they will lose their balance. So if their treatment is such that they're fearful with what they're doing in the treatment, their cortisol is going to increase. So they're going to be in a state of fight or flight, so to speak, and they're not going to learn as well. So that's, I think, something to kind of keep in mind all the time, is this patient has so little control that they can be quite afraid of they're going to fall or they're not going to be able to do the activity that you're asking them to do. So when we use the slow, small, soft, that helps to give them more control over their body, and then they're less afraid and more able to learn. So.
So Andy, well, she was a 2-year-old grandson before. Now she is a patient with a cerebellar ataxia. Okay, so Andy, we're gonna work on squat transfers. So you're currently sitting on this bed, and we're gonna get you to transfer over to that chair. I want you to remember those ideas of slow, soft, small movements. And in order to do that, you're going to stay in this squat position, and you're only gonna move one segment of your body at a time, okay? As the therapist, I would be guarding the patient, but I'm not going to do that because I have a microphone. So Andy, I want you to reach your right arm over to the edge of this chair. Okay. I want you to, thank you. I want you to scoot your hips over toward the edge of the table here. Great. Now I want you to move your right leg over, your left leg over. Your right hand can reach a bit further. Your left hand can come in, and then, hold on, one at a time, you're going to lift your hips and scoot over, okay? You're going to move one segment at a time, one arm moves, okay. So, Andy, how do you think that went? Do you feel like you were able to move one part of your body at a time?
I was really surprised by how safe I felt doing that movement.
Do you feel like there were anything that you could have done differently to feel a little better about getting fully onto the chair?
So your your guidance was very helpful, teaching me to go with slow, small, and soft movements. So let's come back. We'll go back.
Okay.
And then we'll add one more thing to that.
So we're going to go back over to the other table, okay? We're going to still apply the same principles. So Andy, you did really well with that. I'm going to give you less cues this time, and I want you to still follow that same technique going back over to the table, okay? Okay, you are there safely. Andy, how did you feel about that transfer?
Feels very good to do it on my own.
Yeah, very good. And then, had there been any very big errors in Andy's movement? Let's say Andy moved her whole body at the same time or wasn't doing a good job of moving one segment at a time. I would want to encourage Andy to troubleshoot and to think through what could have been different about that transfer. I can ask, did you move one segment of your body at a time, and see what she says to that? Did you keep your base really low when you were doing that transfer? Did you place your hand where you wanted to? So I could be prompting or asking those questions to help facilitate Andy identifying if there was an error and where that error occurred. And then I can ask her, Andy, how might you change that transfer the next time you do it to make it a little bit better or safer? So that's encouraging Andy to then take that information and think through, what can I do differently next time to make it better? Okay.
So if we just switch for a minute, so if you were my person.
Sure.
So just something to kind of think about adding as you're doing this. So what I'm going to have you do, Angelina, is squeeze this pillow between your knees. Okay. So the ataxic patient's going to have to rely a lot on their core stability. So they're working on core strengthening, core stability, and then working out to the extremity movement. So they really need to have good core stabilization prior to any moving. So something I might do just to kind of prime the core is to just do some resistive things in sitting before we go to the transfer. So just asking you, don't let me have that pillow, Angelina. Squeeze, hold tight, and breathe. Breathing. Good. Do you feel this working? Okay, good. And hold. Don't let me push you back. Good. Holding, hold, and squeeze. Holding. And one more squeeze. Very good. Okay. So you can let go now. So just kind of getting the core working, priming, feeling that part of the body, and then going to the extremity movements. and the transfer. So I think what's so helpful about this is sometimes these patients, they're not going to improve a lot because they have so much impairment. So if they're trained to move in a particular way, they can be more independent and then they can go on from there. But oftentimes the patient appears so uncontrolled that then family members are helping them transfer. They're kind of doing all the activity for that person, and then they never develop that autonomy or they never feel success in being able to do many things on their own. So this progression with the patient can really make a big difference in how they are able to function on their own. So if they're able to do transfers this way, then we move on to something more challenging. So our next activity is going to be an activity in standing with our ataxic patient.
And I think it's time we need one more volunteer. We have some remaining candy. Yay!
I think we're okay. I just want it braced against there so that our patient's not going to knock over. There we go.
So first and foremost, we'll say we would do this on a very stable surface. So this would be on a wall or something that is not on wheels. So this is just, we are all going to visualize that this is a stable wall.
I don't think so.
So setting up the environment with a lot of visual targets.
So using vision for our patient is really helpful. So we're going to have a chair, so if you're fatigued, we can stop the treatment and then you can take a rest. So let's bring this in a little bit closer to you. There we go. Good. Okay. So what the person will really benefit from, you can have a seat for a moment, is again moving one extremity at a time. So moving a foot, moving a hand, moving an opposite hand, moving a foot. So they're, again, getting some success with that moving in a standing position where they might otherwise feel really unstable. So do you all know Twister, this game? No. So we were hoping to have some time for you all to play. But this goes on the ground, and then we spin a little dial, and it tells you to move your right hand to the red, your left hand to the green, your right foot to the yellow. So you just keep moving until you're all twisted into a position that you can no longer, then you fall down onto the ground. So that's how Twister works. So Film, we're going to have you, we're going to come on up to standing. There you go. So I'm guarding you, and you're going to come a little bit further forward. Good. Okay. So for you to develop your confidence in being able to do some things in standing, you're going to want support. So you can pick a color where you want to place your opposite hand. So where do you want to place that hand? Very good. So we're going to begin here. And what you can do is choose where you want to move if we're going in a side-to-side direction initially. So we're just working with your arms. There you go. So what you can do is go side to side to some extent. And as you're going in these various directions, you have this upper extremity support. So you would move one hand, and then one foot, and the opposite hand, and the opposite foot. So you have support coming from all four extremities because you're just moving one at a time. So in this way, you can be in standing and feel stable and safe, doing your practice just initially with your arms. So I'm just going to ask you to move with small, soft, and slow movements. And you can travel in my direction and then back in the other direction. There you go. Very good. Okay. Good. So was there anything that you noticed that you want to do differently or any error? Okay, so say if you, when you go that direction, you're overshooting your target. So you're going to practice going the opposite direction. And sometimes you want to, I'm going to ask you for the sake of our learning to overshoot your target. Okay, so try to go where you're not hitting the target, so instead you land there. All right? So just in standing where you are, doing some movements with your individual arms, and then overshooting. There we go. Okay, so what did you notice about that? Was there something that you didn't accomplish when you were trying that task? So what was it that you noticed?
I feel it maybe it's like a misplacing of my arm, and maybe it's like quite harder. Yeah.
So she's noticing that she went beyond the target, that she went too far. So so that's the first phase, is recognizing the error. So she wants to recognize the error, and then she wants to state what the error was. So the error was that she reached too far. So she mentioned to me that she reached too far. So then your next step when you practice again is to try to correct that error. So we'll practice again in standing and just moving your individual arms one at a time. Good, and you can go up or you could go down. Very nice. So you're feeling pretty comfortable with that. Good. Okay. So now we're going to have you sidestepping. So you're going to move one foot, one hand, opposite foot, opposite hand. So as it's getting more complicated, again, errors, we would expect the errors to increase. So we're wanting there to be some errors so that she can tell us what they are and how she's going to fix them. So as you travel back and forth again, there you go. You're going to make an error by overshooting, or your steps. Yeah. Maybe you'll make an extra step, or something will be challenging you. Very good. Okay. So we're going to progress one more time. So coming back to the middle. So finding your starting point and then reinforcing again the small, soft, slow movements. So as she gets more comfortable, then the movements, we could ask that the movement be a little faster or that it be a little bigger. So we could change the challenge level with the size of the movement. But what we're going to do is add stepping challenge. So she's going to be stepping to a target with her foot and then moving her hand. So I'm going to demonstrate for you. So here in standing, what I want you to do is you have your arm support and you're going to move your foot and step to the target and then move your foot back down to the ground. So there's going to be a target on either side, on your right, on your left. So that might be right foot orange, okay, or it might be left foot yellow, and back to the center. So it's more complex, so we're going to go through the arm movements and the foot tapping in place. So again, feel free to make an error anytime, and then we'll use that for learning. So, okay, right hand blue. Good. Left foot yellow. Okay. What did you notice happen there? Right. Mm-hmm. So if you're using vision and you're looking for the yellow, so very good. Okay, we'll continue on playing twister. So left hand green, right foot orange, Come back. Good. And right hand red. What did you note? There we go. Okay. Good. So you caught your error and you corrected it. So you want to state the error. So you want to tell yourself what went wrong. So if we go back to that error, so I'm going to ask you now to state what went wrong.
Yeah, maybe a little bit confused. So when I recognize that I make it mistake, so I make it correct. Yeah, I placed my hand on the blue instead of the red. That's so.
Okay, so the mistake that she's pointing out to herself is that she put her hand on the blue rather than the red target. So then she's knowing that, aware of that, and using her higher learning centers to help her correct that the next time she does the movement. So you can see it's progressively getting more complex as we go. So, okay, we'll just do a little bit more practice. You're probably getting fatigued, so we'll have a sitting break in just a moment. So, there we go. Okay, so any comments, questions, anything we can clarify about how we're working with this patient?
Okay. So some of the big take-home messages are how Andy applied many of the strategies for treating an individual with ataxia. She used those learning strategies to try to have the patient identify when an error occurred, what the error was, and stating how they will fix the error. She used soft, slow, and low movements. She used visual feedback. And she was encouraging the patient to be using weight bearing through all extremities, moving one extremity at a time. So there were lots of layers of strategy there to create that intervention for an individual with ataxia. We just want you to know that that's one example of many different interventions. You don't have to have all of your patients playing Twister, although they might enjoy that. But taking those concepts or those big picture items that you saw demonstrated, and you can apply that to many other tasks and many other interventions and strategies. Quadruped, hands and knees, is a really great position to treat someone with ataxia. They get lots of weight bearing in that position. Tall kneeling, half kneeling, seated, and Andy was showing some of the core priming examples when we did the transfer, before the transfer. A lot of those techniques are good for people with ataxia. For gait training for an individual with ataxia, you want to apply the same concepts. So if an individual uses 2 assistive devices, we want to promote more of that 4-point gait pattern to start, right? Do you want to grab the hiking poles real quick?
Sure.
And maybe just demonstrate. So a 2-point gait pattern, right? We have an upper and a lower extremity moving together. I'm not sure, do you all use 2-point and 4-point gate pattern for the physical therapists in the room?
Oh, it's okay.
Is that
I'm
what
just
you
gonna
call
bring them to her.
the gate pattern?
I'll just bring them to Angela. Okay.
Just making sure what I'm saying is translating correctly. So a 2, do you want to just demo? Okay. What we call, I'm not sure if this is how you describe them in Thailand, but a 2-point gait pattern is where the upper and lower extremity move together. So 1, 2, 1, 2. However, I'm moving an upper and lower extremity at the same time, right? So does that apply the principle of only moving one segment at a time? No. So what I would do is, in the US, we call this a 4-point gait pattern, where I'm moving one upper extremity, one lower extremity, one upper extremity, one lower extremity. So 1, 2, 3, 4. Thank you, Andy. 1, 2, 3, 4, okay? It doesn't mean they need to do that gait pattern forever. It means that's where we start, right? If we have them doing that 2-point pattern, it might be too much for them initially when we're doing gait training. So we might want to start with that 4-point pattern, work on core stability, and then return back to try to do that 2-point pattern, okay? Other activities that are really great for an individual with ataxia are figure 8. So whether they're drawing the figure 8 or they're moving on a figure 8 pattern, that continuous movement and continuous flow of movement is really good for re-educating the brain. So that's something that we use as well. You can progress to them walking around environmental obstacles, such as cones or chairs, still in that same figure 8 pattern. Then that adds in a little bit of obstacle negotiation. You can also progress to doing that similar activity, but in an open environment. So I might tell the patient to walk across this room and turn right around all these tables and weave through the tables and come back this way. Okay, so that's just other examples of how you're going to start with an isolated task and then make it more complex by adding other layers, but still focusing on those slow, small, soft movements. Okay, as Andy mentioned, we start with the core. So we're starting with the core strengthening, retraining and educating that core, then working out to the extremities. We're beginning in more stable positions and more firm positions, and then eventually working to less stable positions. Using diagonals and PNF diagonals, it's a way to utilize, we don't always move in a straight line, right? We're constantly moving in these diagonal patterns. So don't forget to add in some of that movement. Andy did that a bit with the twister, right? The patient was reaching on that diagonal movement and having to step to the side. We're not always just moving in a straight line. So remembering to incorporate those other directions of movement. And keeping in mind that high repetition, that high number of repetitions really promotes neuroplasticity and learning. And that's the case with all of our patients with stroke, but it is definitely important for our patients with ataxia. And then tying it back to task-specific practice. So making it meaningful for the patient. The patient is going to learn more information and learn better when the task is specific to something that they love or they enjoy or that they have done before, right? So making sure that we're incorporating what is valuable, what is meaningful to the patient into their treatment session. Okay. So we're not going to necessarily go through the FGA or the functional gait assessment, but it is an outcome measure that you can use for individuals with stroke to assess more complex motor tasks while walking. So they're walking and turning their head, they're walking and stepping over an obstacle, they're walking and turning around, they're walking with their eyes closed. So doing those tasks can be a really good higher level tool to assess if someone is maxing out on a tug, a timed up and go test, or some of the other outcome measures we might use for our patients with stroke. So keep in mind, if you haven't heard of or tried the FGA or the functional gait assessment, there are links here. It's pretty easy to perform. It's pretty self-explanatory. You would read the item, have the patient perform the item, and score them. It also helps drive interventions because whatever items are difficult or challenging for the patient, you can turn that into an intervention. So I'll briefly talk about an example where a patient might have path deviations. When they're doing the assessment measure where they're walking and they're turning their head side to side, they might be deviating path while they're doing that, right? So one example of how we might treat that would be starting in a stationary position. So we might start the patient standing on a firm surface with a wide base of support and practicing maintaining their balance, keeping their core stable, and turning their head to one side, coming back to the center, turning their head to the other side, coming back to the center. They're working on core stabilization. They're also working on maintaining their balance without relying on as much visual input because their vision is giving other information while they're having to maintain their balance on that surface. A progression could be changing the surface. So maybe I want them to stand on an uneven surface. I'll have them stand on a foam pad and do that same task. Once they get better at doing that in that static position, then I can start to incorporate that into movement, right? If they weren't good at doing that task while walking and they're deviating, I need to address the problem first in a stationary position and then return back to the dynamic position of walking. When the patient is walking, I might make that task a bit easier at first. I might have them turn their head every 3 or 4 steps instead of every 2 steps. I might have them pausing and looking ahead for a few steps before looking the other way, and then eventually looking side to side with each step, okay? So all of those are examples of progressions you might do within that same practice. Any ideas of how you might make it harder from there? Let's say they're doing well with that task and turning their head side to side. How might we make that harder? And the answer is on the board if you... What's that fourth? Or sorry, what's that fifth? The second to the last one. Varied surfaces. Yeah, so we might have them doing that same task, but now on uneven ground. Are we always walking on this beautiful flat surface? No, right? We want this to translate into the real world, into outdoor surfaces, into their home environment where they might not have a level surface. So doing that over varied surfaces can be the next progression. And then an additional progression might be having it be more task specific. So do I want my patient to just be really good at turning their head side to side while walking over an uneven surface? No, I want them to be good at doing that so that when they're at the grocery store, walking down the aisle and looking at what they want to get, they can keep a straight line and maintain their balance, right? I want to make sure that if they're walking and they're crossing a street, right? And I learned that here you have to look a lot to make sure you can cross a street, and then I go and I don't go. So you want to make sure they're able to keep their balance when they're looking both ways to cross a street, right? So we're adding in some of those functional tasks. I might take them outside and have them cross a street. I might put cones throughout a room and tell them to scan the environment and find the cones as they're walking. They're doing the same task, right? They're walking with head turns, but now they're doing it in a functional way, okay? So that's an example of a progression of someone who has a deficits just in that one area. You can do a similar structure for other items on the functional gait assessment as well. That was just one example. Okay, any questions on the ataxic patient and the ataxic assessment, the SARA, or on the functional gait assessment, or on anything we demonstrated here?
Just going to pose a question to them.
No questions? Okay. All right, well, thank you very much.
So we were wanting to know from you all, when you have your patients come, it's just posing a question about, is there an endpoint to recovery from stroke? So often our patients, they're informed when they ask when they will get better or how long they can continue to improve. You know, sometimes or oftentimes they're told in a year you may have regained most of what you will regain, or maybe 2 years. So when you all have patients that you see and they're talking with you about their recovery, we're just curious about your thoughts and how your patients are asking those questions, or what you might be telling them when they ask, will I keep getting better? So am I going to improve? So does anyone have any thoughts on what that conversation is like for patients that you see?
And do you have those conversations ever? I think that's the first question.
Good point. So do the patients ask those questions? Are they given any guidelines? Are they given any, when they want to know how long will they continue to get better?
May we share our experience with ataxic patient? They ask us the same question as you mentioned, but we tell them like we see the progress is day by day, and we show them like the outcome measurement, like moving, how they can transfer themselves, how can they sit to stand by themselves. They will know themselves how much they feeling better. But I have one more question for you. We have some patients who have limb ataxia, and we always see some therapists put the sandbag on the foot while they are walking. What do you think about we are putting the sandbag? It can help for the ataxic while we are training for walking. Thank you.
Thanks. I really like your comment about giving the person that you're just saying we're going day to day and we're seeing how things go and how you're feeling versus saying at 1 year you will no longer gain any improvement. And then the question about adding the weights to the ankles or to the torso perhaps. Right. So I think it can vary with each individual patient. So often what we're trying with people is we might try adding the weights and seeing if that's beneficial to them. I don't think there's a lot of evidence to indicate that it is beneficial to them, but I wouldn't want to ever say that it won't benefit a particular patient. So I think it might be something to try. What I have used with ataxic patients is using the TheraBand, the long pieces of TheraBand, and wrapping them around the ankles and the knee and the hip and around the pelvis. And so it provides more information, maybe more so than the weight would at the ankle. So if you use that compressive force of the TheraBand tied around the ankle, knee, hip, and around the waist, on both sides, that can give them more information, or maybe just on one side that we would use the TheraBand. So that may be something to try. You're welcome. Does anybody else have thoughts on how long patients feel that they have going forward to recover?
I'll share that in the US, patients are often told that recovery stops after a year, or sometimes they're told after 2 years. And so we're curious, and that's not true, which Andy will share in a moment, but we're curious from your perspective, do your patients, are they told something about recovery? Are they given a time frame as to when recovery slows or stops? Or is that something that's not necessarily discussed after a stroke?
Yeah, so from my experience, like I have a lot of foreigner patients that came in and they have been told like after they got a stroke, they gonna stop healing after like 1 or 2 years. But then I gonna tell them that it depends on by each patient. So I can tell them like keep on practicing. And normally a lot of people from my experience get keeping better even they get like stroke after like a couple more years. So I would tell them like keep trying their best first and see on day by day how would they keep going.
That's encouraging to hear, because what I notice with patients when they're given a timeline like that at 1 year, then their motivation really declines. They might get really depressed, so I think that kind of input is not at all helpful to them. And in our experience, my experience, I feel like there's no endpoint for recovery, that they can continue to get better, again, based on practice, based on their environment, based on their family support. There's many things that would help people to keep recovering. So back to our ataxic patient particularly, it takes them a very, very long time to improve and lots of repetition, because the part of the brain that's telling them how to move is the part that has also been damaged. So for them to regain the memory of those movements can take a very long time. But we're seeing patients that are 3 years post-stroke, 4 years post-stroke with ataxia who are making really positive gains, but I think in part it's due to the training. So how they're trained to do movements. And then I think for all of you, you know, how much the family wants to help or get involved in helping the patient, and sometimes they're helping too much. And so it's difficult to have family not help too much so that the person can realize the gains and feel good about making those changes. So anything else that anyone wants to add?
For the last question.
Okay.
Question is, if patients have the meaningful goal, but we try to do it, but still harder for him, and do you think we should try more and more for a long time, or if 3 times or 4 times and cannot, maybe step back to choose the another task training or not?
That's a good question. So what comes to mind is pacing. So if the person is getting fatigued and that's why they're having a hard time learning the meaningful task, so maybe seeing them in the early part of the day when they're more rested, or doing a part of the task rather than the whole task, and seeing if they can make some progress on that part of the task and then adding another part. So if the whole task is too challenging, then we need to find a way to have a smaller goal. So, or pick a better time of day for the patient. Or there may be other things going on, you know, as far as their mood is concerned, or they may just have low energy for other reasons. So, but I think you have to approach the patient in ways where they're feeling success. So again, if you continue to try something and they're not successful, then moving to a different task.
So I'll share an example from a patient that I had. So his goal was to return to golfing. Do you have golfing? It's like 4. So the patient, they weren't able to stand or ambulate. Getting onto a golf course wasn't feasible. They didn't have the coordination. They didn't have the strength. Like there were many barriers why this wasn't feasible. But the patient's goal is golfing. So we started off in a seated position, and the precise movement of hitting a small ball with a small golf club into a small area would have been too much. So we gave him this like very big, it was like a foam roll, like a half foam roll that's very big, easy to grip onto, so it didn't require as much fine motor control. We had a big like volleyball, a volleyball, and he would hit it into a soccer net. And that's what we started with. And he was in a seated position, he would use the foam roll, he would hit the volleyball into a big soccer net. But the principles of golfing were still there, right? We were still doing a similar movement, a similar idea. The joy of getting the ball into the target was still there. And then over time, we were able to change that. So as he became more stable, we started to do some of it in standing, some of it would still be in seated. We were able to, once he gained more fine motor control, he could use a smaller, maybe not a golf club, but something that was smaller than the foam. We started to use a tennis ball versus a volleyball. So was he golfing? No. But was he enjoying an activity that brings him joy? Yes. So I would say, similar to what Andy stated, like breaking down the task into smaller parts, or maybe modifying the task so that it's similar to what they want to do, but maybe it's you're being a little bit creative in how you deliver it.
Thank you.
Okay, it's time for close this conference. Okay, let me invite Mr. Peter Scott Patumarawan. He is a rehab director, to give a thank you speech.
All right. Thank you so much to Andrea, Angelina, and Catherine. We, on behalf of BDMS, we're all very grateful for your sharing expertise and knowledge on all the things that you did this morning on stroke rehabilitation, not only how you assess, not only the key points that you've covered, as well as just treatment value ideas, and just the interactive nature of your presentation was really much more engaging, and I think that really helps just drive these points home for everyone that is watching and in the room as well as home. So I thank you again for coming all the way to Thailand and sharing that with us. I think on behalf of everyone who is here, as well as those who have gone to OHSU, they've all had great experiences and good things to say about their time there, as they always have. They always come back with enthusiasm, and they're planning on how to teach the rest of our team here at BDMS on how to take those knowledge skills that they've learned and then transfer it to our patients here. And as Dr. May said earlier, the goal, in the next 2 to 3 years is to standardize the treatment, starting with the stroke diagnosis for all patients throughout the network. So I think everything that you've shown us today serves as a good foundation as to what to build upon, and then obviously based on the resources available to each hospital, things should vary slightly. But overall, the concepts, the goals of the treatment, everything that you've said are going to be standardized more so as we use this knowledge in our corporation here. But the other thing is the later today we're going to have more case studies for you to answer more questions, but thanks just for answering the questions we've had this morning. I think the team's going to have more formulated questions, but I think everything you've said was easy to follow and easy to translate to care. So I think everyone's going to use some of the things they saw today and choose in their head which patient's most appropriate, and I think we'll, just as we always do with continuing education courses, want to find that right group to use it with. I think that's what we've gotten from this morning's session. So thank you again for your time and your sharing your expertise and knowledge with us this morning, and we welcome you to Thailand for the first timers, and we hope you enjoy the rest of your week here, but from now we're going to try to give you some suggestions of what you can do over the weekend too, okay? Okay, so thank you so much, all right? Thank you very much.